Maharashtra today, and I'm thankful for all those who have managed to come even out of Maharashtra, like Dr. Jha sir is here. I'll request Sanaya Mehta, who's our collaborator and a psychologist by profession, to do the honors for working as a master of ceremony. So Sanaya has been a very promising student in psychology. She has been with us for many years, and now she's practicing as psychology and mind body medicine specialist. So over to you, Sanaya.
Thank you, ma'am. Good morning, everyone. It gives me immense pleasure to welcome you all to SYNAPSE 2026. Organized by SPEAR in association with the Maharashtra Endocrine Society, the Center of Behavioral Medicine, and the Indian Psychiatric Society. We are delighted to have an esteemed panel of speakers and participants with us today. And we look forward to an insightful learning, engaging discussions, and meaningful experience today. To formally begin today's conference, it's my privilege to call upon Dr. Vaishali Deshmukh, an endocrinologist, the secretary of SPEAR, and a leading advocate of mind body medicine, to deliver the introduction.
We all know that Sphere has been a part of organizing activities for prevention and education in non communicable diseases. And our journey, especially with obesity, if I can tell you that it started in way long back in 2006 with Abbott launching their first molecule, that was sibutramine, in the market. And I remember that the first obesity clinic that we set up in Pune was in around 2007 and 8, and that was when orlistat and sibutramine were in vogue during that time. But being as an obese child, an obese adult, and now a doctor treating with obesity, obesity has been intriguing me and also grueling me a significant amount for years together. And what I feel is that it still fascinates me because how simple long discussions which we did over a coffee table in our canteen in the hospital. I remember Dr. Leena Madam, Dr. Sanjay Fadke and Mr. Lele and Dr. Vaijayanti and so many people sitting on a coffee table had these discussions why obese people require so many specialities to be seeing them. So we always discuss that obese people need a psychiatrist, they need a psychologist, they need a gynecologist, they need a endocrine specialist, they need also rheumatologist for joint pains. So are we dealing with separate diseases or is it a part of the same disease? Is it a single common soil that we are dealing with? And that's how this whole idea came into vogue. And then after, we were fortunate to have neuroscientists with us, we had neuropsychiatrists, and a lot of research led to us to this framework of PNIE, discovering this. It is already a known entity in neuroscience that psychoneuroimmune endocrinology is a known entity in neuroscience, but it is not applicable to NCDs till we started framing it into this in this segment of non-communicable diseases. So we thought that why not use this framework to define a common soil hypothesis for obesity. So we know that psychology is disturbed in obesity, immunology is disturbed in obesity, endocrinology is disturbed in obesity, and of course rheumatology and neurology is also at toss. So we realize that obesity is not a single disease, but it is a framework of this network which is imbalanced. Now, which is this framework? The framework is the psychoneuroimmune endocrine network which is imbalanced in obesity, and that is why if I have to treat obesity as an obesity consultant, I have to get this network frame into a balance, and that's what is my job, and that is why it's not a single man's job. It has to be a teamwork which are involving team which are likely to correct all these imbalances in this framework. So each one of us who saw these diseases, the NCDs, whether it was PCOD, whether it was infertility, whether it was depression, whether it was hypertension, cardiovascular disease, all these specialities realized that we are dealing with the same disease, same framework getting abnormal. And this has led to this birth of this idea, and that is how we began this education on this concept through our Synapse conference. So I'm sure a lot of you all have been part of the first Synapse conference. This is the seventh Synapse conference that we are doing, but first Synapse conference was done before COVID in 2020. And that time it was the first time that we tried to get this framework into vogue to our audience who are managing non-communicable diseases. So we saw that it was attended by multiple specialities, but everybody thought that yes, this is our disease. So everybody felt that obesity, metabolic syndrome, and diabetes is a part of the spectrum that we also come across. So it just simplifies the thing that we are not dealing with different diseases. We are dealing with a framework of abnormalcy, and that is the PNI framework. So, given that all of us in the team would like to play a role as a good doctor, we thought that why not spread this? Why not take it to training sessions, through workshop, through research, and through service to all? So this was, we have been a part of many trials also with obesity, but our main aim is to train upcoming doctors and doctors who are managing these disorders to understand that you cannot manage obesity as a single organ disease. It has to be dealt with as a framework of PNI being disturbed, and that is what is the aim of this conference. What we are going to do over the next coming 4 years, 4 days, is that we are going to try to see how to stabilize the psychology, how to stabilize the neurology, how to stabilize the immunology, how to stabilize the endocrinology of an obese person. And when you're talking about stabilizing of all these four things, then you're talking of holistic approach or holistic treatment of obesity. So it cannot be a single drug of semaglutide or single drug of tirzepatide helping obesity. It has to be that psychology is being settled down, the immunology is being settled down, the endocrine is getting balanced, and the neurology, the autonomic nervous system is in balance. So when you get this type of a framework, that is the time you will realize that the patient of obesity is fit for receiving drugs like semaglutide, drugs like tirzepatide, and now is the era of newer anti-obesity medication. I think it is more important for every stakeholder, including the pharmaceutical industry, to understand that if you want to treat obesity, only drug is not going to work. You will have to do something to stabilize this PNI framework, and only then your obesity medication is going to help. So our journey has continued through learning, doing, implementing it for ourselves. So we have been practicing. This year we have had a different milestones which we have achieved. One first important milestone was starting of the Synapse conference. Second importance was with starting of a mind body medicine position statement, which was published by the RSSDI, which is the largest national body on the diabetes, and the position statement was published in their official journal. The third important milestone was starting with our obesity and wellness center, which catered to the public for direct achievement of holistic goals in treatment of obesity. And I'm sure all our consultants are going to guide you also as to how we can help the mind body medicine and the PNI framework through non pharmacological means. And then we have pharmacological industry today coming a big way to support the cause, because they also have understood the implication of getting obesity under control as a mother disease. So I'm sure all stakeholders understand that obesity is a mother disease, and it has to be under control to prevent many of the non-communicable diseases like hypertension, cardiovascular disease, depression, and so forth and so on. So I think that every stakeholder has a win-win situation to help a obese patient, and multiple stakeholders like CBM, Sphere, Public Health Organization, NIMHANS, societies like Endocrine Society of India, Maharashtra Endocrine Society, RSSDI, many global leaders like Dr. Professor Gangadhar sir, who will be there with us, and Professor Dr. Norman Sartorius sir, who is a part of the WHO, played an important role in getting this whole framework and helping us with managing the comorbidities related to all the NCD. And we are thankful to the pharmaceutical industry for supporting us all these years. So 7 conferences being run with your help, And I'm grateful to all of you for being a part of it. I'm also thankful to all the delegates who have come up from big places outside Pune and been here sharp at 9 o'clock for this particular conference. So the encouragement and motivation from all the stakeholders has been phenomenal, and it has actually helped us to get motivated to do more and more activities in this regards. So our mentors always have focused that NCDs are not different diseases, they are a single disease. So if it is a single disease, why not understand it properly, and why not get into the teaching learning mode? And that is why it needs a teamwork. We have different specialities speaking on this forum in this conference, and I'm sure that it will be an interactive session. You'll enjoy this conference, this learning, as well as sharing over 4 days to come. So our purpose has been to convert education into training, followed by research, and now we are going into more of service to community. So our journey has been very fulfilling from conceptual lay down to laying the foundation of this PNI framework, to taking it into research, into training, and now working for the benefit of community through our obesity centers. So the journey has been rewarding, but it has been very tiring. So I keep on saying every year that I'm not going to do it next year, but every year I feel that the need is more and more, and it's more of a need in the society than I need to. And till I can help the cause, I will be doing it. But I would always want every one of you to take this forward and at your own pace, and in your own cities, so that it doesn't become a tiring job for people like us. So I hope you all will enjoy this academic feast. And now we move on to the scientific deliberation. Thank you so much for one and all. Thank you.
Thank you, ma'am, for the warm welcome. To begin our scientific deliberations, it is my pleasure to invite Dr. Leena Fatke, Professor and Head of Navle College, Pune, internationally trained in mind body medicine from Harvard Medical School. Dr. Fatke is also recognized for her pioneering work in autonomic neuroscience, diabetic research, and integrative medicine.
My pleasure to be here, and I thank Dr. Vaishali for giving me this opportunity to have a discussion with the delegates. I don't want it to be kind of a didactic lecture, but interactions, I will prefer interactions. But so this is my CV, and next my presentation, please. This is the opening kind of batsmanship that Dr. Vaishali has given me to open this conference, and I will try to give you a gist of the whole conference, that what we are going to present, what different speakers or guest speakers will be talking about, and why madam and the whole team has selected this topic which you are seeing in your conference menu. So my topic, it is neurophysiology of obesity. As the name suggests, neurophysio of obesity. What it indicates is that it's not a kind of a single organ disease, it's a multi organ or multi systems disease. And what exactly happens to all those systems, madam has just given you the idea about it, that it is involvement of PNI network, psycho neuro immune endocrine axis. But what exactly the biology of obesity that is there, I will try to give you the idea. So all of you know that obesity is abnormal or excessive fat accumulation that pose a health risk. So it's not just kind of accumulation of fat, but it is posing a health risk, and moreover, where the fat is deposited, that is more important, whether it's a central or peripheral or subcutaneous or visceral, that matters more. So, as the name suggests, that obesity is not a single organ disease, it's a systemic dysfunction which affects especially the energy homeostasis. And all aspect of energy homeostasis, whether it's input of energy or energy release process, that is metabolism, then the utilization of energy as well as storage. So all component of energy metabolism, it is affected, and it is a classic example of what I say is dysfunction of all the regulatory mechanisms. In our body, we are being provided with three important regulatory mechanisms. One is homeostatic, all of you know, allostatic, and then third one is a voluntary regulation. What this homeostatic, allostatic, and voluntary, I will tell you afterward, but these three basic regulatory mechanisms are there in the body, and in obesity, all these three mechanisms, they are affected. So it's not just the homeostatic component, allostatic as well as voluntary regulation is affected. Moreover, there are many factors which actually results into this dysfunction, and therefore it's a multifactorial. There are many modifiable, non-modifiable factors which affects the obesity, development of obesity, and obesity. What in I think in the evening we are going to present you with some new concept that obesity must be understood with the framework of capacities that human beings are having and the load that has been put on the body. So, load and capacity framework for management, for understanding of obesity. It's a very, very new approach. Next. This homeostatic regulation, what we have is here and now type, reactive, and works around a predefined set points. So in obesity, we are having predefined set points. This is one theory that is there, that there are certain neurons which have set points for different macronutrients, for the weight itself. So whenever there is any change that happens, either in your eating or your in physical activity, if there is any disturbance that happens in a weight at a time, in a shorter way, you can say very acutely, then being having a set point, body has a method to bring back the weight again back to normal. So whether there is temporary increase in weight or there is a loss in weight because of any reason, the body via this mechanism tries to bring it back towards normal. So this is what is the concept of set points, or we are having those neurons which actually determines that. Then I'm sorry. Allostatic regulation is a predictive regulation. The body has been given this predictive kind of mechanisms, which, like for, if you have seen that why during stress there is increase in weight, because we have this predictive mechanism which actually prepares the body to face the challenges. How this will work, we will discuss afterward, but you are having homeostatic, allostatic regulation, and voluntary. Voluntary is a top-down approach. Voluntary is top-down approach, which is having a long-term effect and can override your homeostatic and allostatic regulation. So this is very, very, I think, important regulation which we normally not use for management of obesity. We will discuss about this afterwards. So homeostatic, allostatic, and voluntary regulation and dysregulation of these modes, they set the ground for obesity. So disturbances anywhere, whether in homeostatic component, allostatic component, or voluntary regulation, that results in development of obesity. It's a very basic diagram. All of you know that weight gain occurs if there is increase in input or there is decrease in output. So all the mechanisms in the body, they are geared towards regulation of the body weight by balancing the input of energy and the output of energy. All regulatory mechanisms, they are directed towards this. These are three instinctual sensations that control our feeding behavior: hunger, appetite, and satiety. Hunger, it's a physiological sensation. It occurs because of the biological needs to eat to maintain the energy level. It is an unpleasant sensation. So hunger, it produces unpleasant kind of sensation in brain. Appetite, on the other hand, it is a desire to eat food. It is also a sensation that can be affected by emotional and environmental factors. And satiety, it is a opposite of hunger, and it is the sensation of feeling full. It's a pleasant sensation. So you are having now two opposites. You are having hunger sensation and satiety. And your whole homeostasis, allostasis, and voluntary control, they are geared towards these two sensations, hunger and satiety. If you are too hungry, you will eat more. If you are too full, that is satiated, the eating will stop. So all our mechanisms, they are basically geared towards this. This is very busy slide. So from this slide, you can understand that obesity is a very complex kind of disease. It is not a single organ failure. It is not a single mechanism failure. It is not a single pathway failure. Multiple things are involved. I will try to be more quick about this, but this is going to be the basis for all the lectures, for all the speakers who are going to speak about this only. So I think understanding this is very important. So I will start with this central aspect of this slide. The integrated center, the one important area in the brain which regulates body weight is hypothalamus. You are having two different sets of neurons in hypothalamus. One is called as a hunger or exogenic pathway. You are having the NPY neurons and agouti related protein neurons. So these two different neurons are there. Then another set of neuron which results, the stimulation of which causes satiety. They are POMC or CART. POMC is pro-opiomelanocortin and CART is cocaine amphetamine regulatory peptides. So this hunger and satiety centers are there. Now here you can see both of them has a inhibitory effect over each other. So whenever one is stimulated, it will inhibit the other, and the other is stimulated, it will inhibit the other one. Let it be like that. Okay. So you can see over here, when hunger center is stimulated, it affects the lateral hypothalamus, another set of neurons, another set of nucleus in hypothalamus, and it results into feeding behavior. While when the satiety center is stimulated, it affects or it stimulates the another set of nucleus in hypothalamus called paraventricular nucleus. It induces satiety and enhances energy catabolism or energy expenditure. Now, these two and the hunger and satiety center, they also affect the autonomic centers, which are present in medulla. And they, by stimulating or by inhibiting autonomic center, they manage food intake, energy expenditure, glucose metabolism. So these centers, they are present in hypothalamus. Now you are having different neurotransmitters which are released from these centers, which induces either hunger or satiety. And these neurotransmitter becomes the site where all our pharmacotherapy acts. So you are having, hunger side, you can see you are having neuropeptide Y, AGRP, agouti related protein, ghrelin, orexin, dopamine. while on the satiety side, you are having alpha MSH, SCART, serotonin, norepinephrine, and CCK. So these neurotransmitters, they are being released from this. Now you are having very important mechanisms that can modulate these neurotransmitter release from hypothalamus. So you are having peripheral modulator, which you can call as bottom up, where the hormones, local hormones or stimulation of autonomic nerves, especially of vagus, from a GIT, they all have effect on these hypothalamic nuclei. So from stomach, release of ghrelin. Ghrelin, you know, it stimulates hunger. Then from adipose tissue, you are having adiponectins, which also affect the hypothalamic centers. From pancreas, insulin, which affects the centers. From gut, you are having different hormones which are released. CCK, GLP-1, polypeptide Y, then even GIP also there. For other signals, you are having endothelins like that. So many bottom up signals, they go to hypothalamus and affect these centers, thereby changing your either leading to hunger or satiety. The next important mechanism which also affects this is the top down approach. So your cortex and the limbic system also influence this hypothalamic center. So you are having cerebral cortex, especially your frontal cortex, which affects the cognition. Then you are having a limbic system, which by this mesolimbic pathway, you are having a reward center. So whenever you eat something, if it gives you a pleasant kind of sensation, it is taken as a reward and it enhances that kind. Whenever a person gets a kind of reward, the person tries to repeat that action, and therefore the how much the quality of that food is to produce the reward is going to decide that whether the person is going to binge it or not. So that's why this is a typical top down approach that you are having. So your cognition, your mood states, your emotions, they all affect your hunger and satiety. Then I have already described you about these set points. So these three specific neurons are there in hypothalamus: glucostats, aminostats, and lipostats. As you know, stats means they're the set point deciders. So these are the neurons which are available, which because actually why the person feels hungry, because there has to be some kind of neurons which should fire whenever there is a change in the macronutrient levels. So these neurons are nothing but they are the set point neurons, because they fire and then you get the sensation of hunger or the sensation of satiety. So this is one very important, you can say, theory which runs in obesity, the set points. Either there is a change in set points, therefore all the mechanisms are geared towards increasing the weight. Suppose your set point is, say, for a person is 65 kg, and by some mechanism that set point is changed to 70 or 80 kg, then all the mechanisms in the body, they are geared towards increasing the weight towards that set point, like happens in fever also, right? So this theory, I think, is very, very important. Then this busy slide. Apart from having this neurobiology of different neurons that you are having, different neurotransmitters that are being released, there are many other factors, many other loads that can have an effect on development of obesity. And I think in our workshop, we are going to discuss it more about it, that how to assess these loads, because unless we don't know about these loads, management of obesity becomes very difficult. So you are having constitutional load, you are having developmental load, you are having inner drive load, then external drive load, and the metabolic or physiologic drive. All these loads, they converge on the neurobiology, that is on the hypothalamus and the brain areas, which we have seen in top down approach, which affects the hunger and satiety. All these loads, they have a effect on setting of your neurobiology. So if you are having genes which promotes obesity, your set points are going to be different, your neurobiology is going to be different. If there is some developmental kind of issues, how is the parenting, what is the stress level that the child has faced during a childhood, so the adult has faced during childhood, so these sets the neurobiology at a different level, and that's how the weight gain occurs. Similarly, inner drive load, people have different willpower. So if I born with a different willpower, it is going to have impact on how much I am going to adhere whatever the doctor suggests to. If my willpower is less, of course it is going to affect. I may not adhere to whatever, or I may not compliant to whatever the doctor has suggested. So inner drive load is there. Then external drive load means in the environment in which the person is living. If it's obesogenic environment, definitely it's going to add up in the obesity. So the environment in which person is living, and of course the other comorbidities. Dr. Vaishali has also mentioned about it, that if there is insulin resistance, inflammation, hormonal imbalances, even the gut microbiome. Now we know that a lot of good bacteria and bad bacteria, they also have an effect on development of obesity. So the gut inflammation, gut microbia, sarcopenia, chronic diseases, and iatrogenic, lot of medications which we use, they also change the neurobiology. You have seen in hypothalamus that neurobiology is changed by those medications. That also affects your obesity. So that is very important. So this constitutional load, all of them, they converge on this neurobiology. And very important thing that happens is the development of this positive feedback or a vicious cycle. Once your neurobiology is disturbed, they affect the load. The load, if it increased, especially physiologic load, if it is increased, again it affects the neurobiology, and this cycle sets in. So that's why, from management point of view, what I try to convey from this is that obesity has to be tackled in a multi-pronged way. A single factor or a single management mode is not effective on long term, because if there is a change in the neurobiology, then it cannot be just corrected by one single way, because many factors have an impact on this neurobiology, and this is what we will discuss in next few the workshops that we will conduct, or the other speakers, they are going to speak about it. You are having lot of medicines, as I have mentioned you. So various speakers will be talking about this, the different pharmacotherapy that is available, which acts on this neurobiology of what you have seen, and thereby try to manage the obesity. This is one important slide which actually gives you the idea that it is not just the constitutional load or developmental load or the inner drive, external drive loads that matters. It is also the capacity of human being, different capacities which gives health. If they are also affected, then they can lead to obesity. And if by some means we are able to manage or enhance those health capacity, then this obesity load will automatically decrease. So you are having capacities on one side and load on other side. Even if you are build the capacities, the same obesity load will be managed better by the person. So it is not just to reduce the load. If we are able to enhance the capacity, and what those capacities are, one very important is the sleep. Good sleep hygiene have a very important role on the obesity. Cognition, self-control, daily engagement, hope, sexual health, euthymia, vitality, and GI health. These are the different health capacities which are given to us. If we are able to target them along with the load reduction therapies, I think the management of obesity for long term management of obesity will be more, you can say, effective and more beneficial for the patients. So I think from this you get an idea, a gist that lot many things are involved in obesity. You are having a complete brain networks which works for either hunger, satiety, and for weight maintenance. Various neurotransmitters are involved which affect these centers. Various loads that are there, right from constitutional load to the physiological load which affects the obesity. Various capacities are there which also have an effect on obesity. So if we are able to assess the patient based on this framework, you will get an idea about the how much asset the patient is having and how much load the patient is having, and then appropriate management or the framework for the management is possible. Thank you so much for patient listening.
Thank you, Leena ma'am, for the insightful session. Now we move on, and I call upon Dr. Vaishali Deshmukh to present obesity as a PNIE network disease.
So thank you, Leena madam, for setting that stage. So now I'll move on to my presentation. Can I have the second presentation? So when we are talking about a network loop, the important most task is to get this network into a balance. So what are these networks? So when we are talking of obesity as a PNI disease, the most important feedback loop is that whenever the nervous system is affected, so whenever the nervous system is involved, the endocrine system tries to respond to this through neurotransmitters and hormones. And when the endocrine system gets affected with this, the cytokines and hormones come into picture. Thereafter, when the cytokines are affected, the immune system comes into picture, and then again the neurotransmitters and the cytokines together act on the brain. So we hear a lot of neuroinflammation when we are talking about obesity. So neuroinflammation, neuroplasticity, all these are terms which are affected when this system is affected. So it is a framework of psychoneuroimmunology which is getting affected in obesity. And why is it so? Because we know that our thoughts affect our mind affects our endocrine affects our immunity, and in short, our immunity affects the mind again. So all these are interlinked. So you don't expect that when an obese person is seen, it's only his metabolic defect which is at fault. There is a lot of defect underlying this. So all these systems are affected. So why I am trying to say that PNI is an integral part of all the NCDs. So you can see that the specialty wise, if you have to see, the endocrinology is the, if you have to take example of this, so diabetes and obesity, followed by depression, followed by autonomic dysfunction, followed by immune dysfunction. So all these problems are very common in endocrine system diseases. Similarly, you take, say, for example, cardiology. Hypertensive patient will have anxiety, they will have autonomic dysfunction, they will have insulin resistance and diabetes. So any disease you take the right hand side, neurological disease, psychiatric disease, rheumatologic disease, cardiologic disease, or a gastro disease. Simple example, if you have irritable bowel syndrome, so say if you have motility dysfunction or disorders, then anxiety, gut motility, gastritis, enteritis, all this occurs simultaneously. So I expect that when I'm seeing any non-communicable diseases, all these four systems are affected. So if I'm treating a patient of IBS, I will not treat only with anti-motility agents. I will also treat the psychology. I will also treat the neurology, because then I'll be treating the patient holistically. So this is very important, and it's true for every branch. So every person who is seeing non-communicable diseases has to see in light of this. So what is the psycho aspect of obesity? It's a big etiological factor. You can see that lot of factors in obesity are obesogenic environment. So basically, emotional stress, deep sleep deprivation, and then epigenetic factors and menopausal factors. All these factors are very importantly associated with psychology. So psychological imbalances are very important in the causation of obesity. So most of the time we have seen that early childhood stressors are very important cause. बऱ्याच वेळेला आपण बघतो डिप्रेशनमध्ये गेल्या पेशंट आणि सडनली तेव्हा पेशंट ब्लोट्स अप. Vice versa, in puberty there is something set in the puberty, and the psychological factor has incited the obesity. So that's a very common happening. And of course we have a obesogenic environment into this. So we have an environment which causes more obesity and makes a person more susceptible. So in these conditions, the conditions of emotional stress and sleep deprivation, there will be excessive eating. So hunger will be affected and the whole axis will be reset, because there is a abnormal psychology to it. So you see that when a person is depressed, they will go to the kitchen, they will have more depressive binging, they will eat more sweet food. So that kind of behavior changes occur. So how weight up impacts the mind? So if I have obesity patient, it is reverse also, that obesity itself is going to affect the mind. How is it going to affect the mind? The brain health. The brain health, the risk of dementia, cognitive decline. We know insulin has a direct relation with the brain cells. So there is a high chance of brain health affection. Mental health with mood, anxiety disorders are very common with obesity. Quality of life. Now, quality of life is not only a physical entity, it's also what we label as euthymia, what a person feels inside. So that is also gone for a toss, and there is also a lot of stigma and discrimination which comes up when you're talking about obesity. So the society has more of a negative connotation when you're talking about obesity. You don't see that happening with thin people. It's not a very common happening to label stigmatize thin people so much as obese people. Then brain structure. You can see that structure, there are structural changes. There is the actual thinning of the brain cells in obesity. So there is a lot of cognitive decline which occurs. So you see that they tend to forget early. The menopausal changes, which are labeled as aging changes, are actually related to weight gain during this. And this sets in the immune axis to cause brain inflammation. So brain inflammation is one of the factors. We have heard entities called as benign intracranial hypertension. We have heard the migraine occurring in patients with obesity. And the reason why migraine occurs, one of the pathways is also inflammatory pathway. Then brain dopamine goes down. So the happiness quotient of a person goes down with this. And then brain derived neurotropic growth factor. So brain growth actually comes down. So you can see that the obesity is one of the diseases which affects the brain and the nervous system very badly. And that is why one should actually, so if people ask me that I'm not disturbed with my obesity, what should I do? I should control it, either I should take treatment. The answer is yes, because it is a mother disease of so many things to come in future. So you do have to control it irrespective of that. Then it's a bi-directional relationship. So food is a way to cope. Again, a person with depression is going to eat more. When he eats more, he's going to put more. So that is the way it's going to happen. They also tend to make poor dietary choices. And serotonin deficiency is very common because of all this. And that's why they tend to eat wrong food and some pleasure giving food. So you see that there are certain foods which will give you more of serotonin, and that is why one will go towards that. And then of course the physical lack of energy, because they don't tend to metabolize fat as fast, so the BMR is low. So that's why they feel lethargic. Even you see this happening even if they are not overweight. Lot of normal looking people also will tell खूप आळस भरतो. खूप आळस का भरतो? Because their fat is not functioning properly. So that is why the problem, and that is why fat functioning is going to be at important. So one needs to understand that when we are talking about obesity treatment, we are talking about fat health. We are not talking about BMI control. So one needs to understand that adipocyte function is what we are talking about. So adipocyte function can be abnormal in a 30 BMI person, in a 20 BMI person, or in a 40 BMI person. So irrespectively, any person who is lean or thin. So unfortunately, BMI is used as a proxy measure of obesity. It is not so. BMI is one of the parameters, but any BMI can have fat cell dysfunction, and the treatment of obesity actually focuses on improving fat cell dysfunction. So I will use semaglutide even for a person who is BMI of 20 if the person has evidence of fat cell dysfunction. So this relationship has been bidirectional. The prevalence of depression is 2 to 3 times more common in obesity as compared to the other people, and depression, anxiety and obesity all go hand in hand. So nearly 3 times the normal prevalence of obesity and depression. So there is a bidirectional association. You can see as this BMI rises, the depression also rises. So this, and vice versa, when the depression comes down, the BMI also comes down. So this is a vicious cycle of obesity and stress. Then coming to neurology, how is neurology affected? So autonomic nervous system is the one which responds to any stress. Now we know that obesity is a metabolic stressor. So any stress in the body, whether metabolic stress or glycemic stress, is known to increase the problem with the autonomic nervous system. And now actually the thought that whether obesity is a disorder of neurotransmission, in fact there are certain new researches going on where they are trying to change the way the neurotransmitter transmission is occurring in the synapses so that the feeding behavior is altered. Similarly, you can see that this is the cycle actually. So you change the gut-brain axis, you change the neuroinflammation, you change the mind, again the obesity sets in. So this whole cycle will keep on continuing irrespectively. What about the gut? Gut, how does it cause or how is it related to obesity? So lot of depression and fatigue comes through abnormal gut. Gut microbiota are important organs in deciding how healthy a person feels, because we have been taught only two nervous system. One is central nervous system and second is peripheral. What we haven't been taught is enteric nervous system. So our gut is also a mini brain. So when we are not eating properly, when the gut is not healthy, our mini brain is affected. So when a mini brain is affected, we are affecting the central nervous system and the peripheral nervous system all together. So gut microbiota and metabolic, we have a talk on gut metabolites, and that gut metabolites, how it affects the energy of the person. So what you eat, there was a saying in my childhood, my mother also used to say that we are what we eat. So the reason is that we are eating wrong these days, we are also feeling wrong, and that is why we are also behaving wrongly in terms of our metabolic health. So we have to eat right, right? The food amount, the type, the gut microbiota, the gut health, everything decides on how we are going to improve. Then the endocrine aspect. Now the mind, gut and endocrine link is very complex. So you can see that the lifestyle stressors and mental illnesses both are known to occur and affect the brain. Now second, here is the role of the mind. Then comes the role of the gut. Then comes the role of the adrenal gland. And then comes the role of the inflammatory cells. So you can see that it is intricately linked. The mind is linked to your immunity. The moment you get depressed, you start feeling low, you can fall sick easily. Why? Because your immunity changes. Why obese people have same kind of problems that diabetics have? Wound healing hot nahi. Most of our obese people, they are non-diabetic. But why do they have non-healing wounds? Why do they have gaping surgical wounds? Because their immunity is gone for a toss. So they do behave like diabetic patients. So immunity is disturbed in these people, and that is an important part of it. Now you need to understand that the adrenal gland is grossly abnormal in obesity. Adrenal gland is the gland which produces the cortisol. Cortisol is the stress hormone. So what happens is one metabolic stress, that is obesity, will cause another metabolic stress because of a real cortisol excess. So why pseudo Cushing's occur in obesity? Because the cortisol rises in response to all these stressors, whether it is mental health stressors, whether it is physical health stressors, it's going to cause a reflection in the adrenal axis. And unfortunately, we know that when cortisol is low, the immunity is going to, we use glucocorticoids for suppression of immunity, right? So when cortisol is high, they are going to have a poor immunity, and that's how the immunity is at fault in patients with obesity. So this is the bidirectional. Again, when there is a chronic inflammation itself is known to worsen the hypothalamo-pituitary axis. So you can see that when cortisol is high, inflammation is incited, it is suppressed, then immunity goes down, patient gets prone for infection, patient gets prone for flare-up of immunities, and then this vicious cycle continues. There is an entity of obesity related arthritis. I am sure Dr. Kavita will speak on it, but obesity itself is a cause for arthritis. So we have seen that as soon as the fat comes down, the joint pain comes down significantly because the obesity itself is an inflammatory phenomenon, and that is known to induce arthritis. So most of the times we blame it for the weight concept. It is not the weight, it is the inflammation in the body which causes the joint pain. So then we all know that sexual dysfunction is very common. Sexual dysfunction is common in obesity due to various reasons. It is direct suppression of the gonadal axis. So sex function comes down because testosterone comes down. Second important is through metabolic pathway. We know that the erectile dysfunction is the first sign of endothelial dysfunction in the body. So erectile dysfunction is very common with metabolic syndrome. And third common cause is psychogenic, where we saw that lot of psychiatry is involved. So whenever an obese person comes with sexual dysfunction, you have to look at multiple causes, whether it is testosterone deficiency. In females, you would have estrogen deficiency. And in addition, you would have psychogenic reasons and metabolic reasons for it. If they are diabetic, you would have it still more. So that's a big unspoken area in obesity, that erectile dysfunction is very common. So what is important is that when I'm seeing an obese person, I'm not seeing only fat. I'm seeing all this. I'm seeing the psychology of the person. I'm seeing the immunity of the person. I'm seeing the overall, you can say, neurological assessment, the autonomic assessment of the person. And then I'm trying to see as an endocrinologist what I can correct. So a lot of times they feel that thyroid and insulin are the only two hormones which I have to look. But you need to understand that it is thyroid, insulin, and many other endocrine disorders which are very common. Most of the hormones we can't measure. We don't sit and measure leptin, ghrelin, and other factors, but they are also abnormal in these patients. So we have to look for at least three things. We have to look for behavioral factors, we have to look for biological factors, and you have to look for contextual factors. So if you have to ask me what I see in obese people, our proforma is very comprehensive. Around 10 pages proforma we use. But what we are trying to look at is how is the behavior of the person, how is the psychology of the person, are there any biological factors in his history, and are there any contextual associated factors? Like, for example, if a child is having a experience with a divorce in the family, parental divorce, that becomes a environmental factor for that child. So it can be just a simple obesogenic environment induced by the stress of parents separating. So very simple kind of things can really give you a guidance. So this was what we already aimed at in our various conferences done till date. And I'm sure you all have attended the previous synapses. We have tried to put in how mind-body interventions play an important role in preventing all these factors so that we can prevent the further worsening of the disease. We also have tried to create an awareness in other specialities so that they understand that obesity is not an endocrine disease. It is a disease of every specialty. It has to be seen by every specialist who sees non-communicable diseases. And Then we had been fortunate to be a part of our workshops, and we have done a number of workshops till date. This same place has witnessed many. One we've done in Chandigarh. And finally, now, after doing a lot of training, learning, researching, educating, we decided that it is high time we start giving it up to our community. And that is how we started our own obesity and wellness center with all these experts. So we have doctors, rheumatologists, endocrine, psychiatrists, therapists we have different referral specialities. And this is the whole team. We have a team of doctors and we have a team of non-doctors, that is the allied specialities, who help our patients in achieving a good PNI. So PNI can, for example, if a person is not sleeping well, the doctor will give a sleeping pill and the counselor or the mind body specialist will help techniques to improve good sleep. So very simple, that you can't just treat with a sleeping pill. Lifelong to sleeping pill nahi de payenge. So it is better that you do it very holistically and synergistically rather than thinking of doing it alone. So I think there's a time to relook at obesity through a PNI angle. And if you want to treat any mother disease of all the non-communicable diseases, the best way is to tackle the fat health of the person. So there were patients who used to ask me, in 2010, people had no awareness about obesity treatment. They used to ask me, Madam, you are also obese. Why don't you want to get yourself treated? So I tell them that we are not treating the weight. We are treating the fat. We are treating the adipocyte. We are treating your fat health. Your fat health is not normal. And that is why we are not going to think of making you thin only. We are going to think of making you healthy through improvisation of your body fat. So that's all in my presentation. Thank you for the patience.
Thank you, ma'am, for the enriching session. Now I call upon Dr. Sanjay Fatke. Dr. Sanjay Fatke is a senior consultant neuropsychiatrist at Jahangir Hospital and Dinanath Mangeshkar Hospital, Pune. He is also a chairperson of the Center of Behavioral Medicine and a pioneer in mind body medicine. Dr. Fatke has made significant contributions to neuroscience research, public health, and integrative medicine. He will now speak on obesity as a neurological disease.
Very good morning. For a very long time, as all of us know, that this problem called obesity was an orphan problem. There were no owners in the medical field of this particular problem. So it is mostly the people working outside of the medical system who had owned up the responsibility to solve the problem called as obesity. So whether it is the gym trainers or some diet people, variety of people who had taken upon themselves. It's good that finally the medical field has woken up to take the ownership of managing obesity. To a great extent, we know that most of such developments, they happen in medicine, once a treatment, particularly a pharmacotherapy, becomes available, which is a nice thing, because pharmacotherapy, although may not provide a complete solution, nonetheless, it becomes a sort of a stimulant or a trigger, which triggers development. And we know that the field of obesity has benefited immensely by that and brought focus on this mother disease. As Vaishali madam said, and I would say that she said very generously, that why should only endocrine people be the owners of obesity? Why can other medical specialties not be the owners of obesity? So, on behalf of the wider, I can say, neurology or neuropsychiatric community, I am also here, to stake claim, maybe part claim on this particular problem, managing this particular problem. In next 15-20 minutes, what I am going to do, the previous two speakers, they mainly spoke about the molecular level, the neurotransmitters and the hormones involved and their interaction, I am going to talk at a more clinical or a system level. And this is the 4 points, or rather 3 points. You already had a look at the molecular evidence, the neurotransmitters, and the hormones. I'm mostly going to talk about the neural networks and the clinical associations of obesity and neuropsychiatry spectrum. I'm also going to talk a little bit, about the shared risk, that why various brain issues and obesity, why they share the whole risk, the epigenetic as well as the genetic component. And then, as Vaishali madam, where she left, that are we really looking at some kind of a shared treatment, a treatment which benefits both or perhaps all the NCDs. She presented a very compelling argument that all the non-communicable diseases, underneath they have a common pathology sort of. The PNI dysfunction is a common pathology in all the NCDs. And therefore, whether we are looking at a prospect of a shared treatment. This whole debate is, you can say, summarized by these people. Vaishali madam also showed you this slide, a mini review which appeared in 2021, 5 years ago, where people raised this scientific question, that is obesity a disorder which is located to brain much more than the fat tissue? Where did it come from? So there were some researchers who were looking at the brain networks, the availability of functional imaging, fMRI and PET scan. It has made possible for us to look at the brain functioning in a dynamic way. So people have been assessing this. Very interesting study in which what they did is that they fed either a normal calorie or overfed diet, to both lean, thin people as well as people who up till now were obese but who had recently lost weight. What you see here in this graph, you can see these graphs. These are the lean people when they are overfed, and also these people. So whether it is the lean people or the obese people, whenever you overfeed them, the brain networks, so default network is a large network in the brain consisting of multiple parts, multiple components. So that whole entire brain goes into a sort of hyperactivity. So it's not just some specific anatomical locations, but the whole brain seems to the default state goes into a hyperactive state. That is how the brain responds, to receipt of calories to it. A second very interesting work, deficit in executive functioning and suppression of default mode network in obesity. Recently, as you know, as a recent advance, it has been discovered, up till now we thought that cognitive difficulties, memory impairment, difficulty to focus attention, difficulty to think clearly, that it happens only either in old age or in dementia. That's not true. Obesity is one of the main drivers of the cognitive dysfunction. As Vaishali madam also said, that obesity has a very disabling effect on the overall brain functioning, executive functioning. Then more research came in, and people found that there are actually structural brain changes. So there is a brain atrophy. So as paradoxically the adiposity mass gains, the brain becomes thin. So you have more fat and you have a thinner brain. You lose the fat and brain becomes larger. So they share a sort of inverse relationship. It's sort of a choice, that we have, whether we want to have a larger brain or a larger adipose tissue. The two don't seem to really go very well together. And then there are, of course, white matter abnormalities similar to what we see in, what is called as a multi-infarct state and other situations. So all these evidence which has been accumulating, you can say over the last decade, and put together, you can see the continuum here. So whether it's depression or anxiety, or whether it's Alzheimer's disease or Parkinson's disease, in short, that obesity is taking the brain towards a degenerative state. And of course, the two speakers before me, they told you the whole bidirectionality. So very recently, very interestingly, Journal of Affective Disorder actually is a psychiatry journal. So it published this research paper, important review article on obesity, metabolic health, and brain health from a prospective cohort. So people are now looking at prospective cohort studies based on these findings as to how the two sort of go together. If we want to have a better brain health. So in that sense, I am saying that why psychiatry or neurology wants also to be a participant they are a stakeholder in the obesity management, because obesity is a definite hurdle to brain health. It's a big risk factor to brain health, completely understood. Based on such kind of a research, you may perhaps ask, that whether it's a one-way street, whether the obesity only impacts the brain, or is there a other way around situation also? Any brain activity, which sort of enhances obesity. Very elegant PET scan studies, they interestingly come from oncology people, because oncology people are often doing the PET scans, as we all know. And they found that this small brain area called as amygdala, I am sure you all perhaps may remember the basic brain physiology which you might have learnt, that amygdala is the part of limbic circuitry and is involved with processing of stress and processing of negative emotions in particular, generally anything which affects us. So amygdala is a source of, roughly speaking, anxiety. Amygdala is a source of fear. Amygdala is a place for insecurity and stress. So whether it is fear, insecurity, anxiety, or stress, it is all appreciated by the amygdala in our brain. So the amygdala activity is a predictor of visceral adiposity. The more amygdala is active, the more is the visceral adiposity. People, in fact, further extended this study that you can simply by looking at the amygdala activity, you can even predict the cardiovascular risk. So if the brain is active in a negative way, in a stressful way, or in terms of negative emotions, that is a big driver, So it's not just the calories that you eat, but whether you are happy, So your happiness determines, happiness has a adverse relationship in that sense, with obesity. If you are unhappy, if you are stressed, through this mechanism which people worked out, very elegant paid studies, they found that that is how the adiposity happens. Another aspect, people studying autonomic system, autonomic dysfunction, like Dr. Leena and together with her other team members and Dr. Vaishali, they found that autonomic nervous system also has a similar role. We know that autonomic system comprises of two components. So one is a parasympathetic component, which is sort of relaxing, and a sympathetic component, which is sort of a activating component. Very often there is an imbalance. So we have a more sympathetic overdrive, and the sympathetic overdrive itself, again, you can see is a common feature across all these. So whether it is diabetes, or whether it is hypertension, or obesity, or cardiovascular disease, or depression, or anxiety, common driver. So effectively, therefore, now we already have these type of reviews, that the complex relationship between obesity and neurodegenerative disease, recent one, or here, from the meta-analysis and large pool of studies, people found that this relationship is essentially bidirectional. So people, those who have a psychological or neurological disturbance, have a high probability to have obesity, and vice versa. Those who have obesity have more brain dysfunction, Those who have more brain dysfunction have more obesity. Similarly for sleep also, so more you can say brain functions. So not just the obstructive sleep apnea, but beyond the obstructive sleep apnea, because one of the important reasons is that there is a leptin deficiency in sleep disturbance. If you don't sleep well, there is a progressive leptin deficiency, and that leads to obesity. Stress and obesity. Dr. Vaishali already spoke about that, the significance of cortisol in it. And therefore, now we have this very influential editorial in the American Journal of Psychiatry. You are perhaps all aware of the Framingham cohort in cardiology. So similarly, in psychiatry also, there is a 40-year longitudinal cohort of nearly 7 lakh Swedish people. And they found that much before the cardiovascular whole metabolic disturbance happens, the disturbance perhaps starts in the brain. In a prospective cohort, of course, you can track that, that what started first. We also know that there are a lot of medicines, another line of evidence. For example, valproate is one of the very commonly used anticonvulsant medicine. Also mood stabilizer, very commonly used. It accelerates fat deposition. Lot of antidepressants also. They also cause weight gain. Antipsychotics, in particular, atypical antipsychotics that we use nowadays, the typical ones which were used previously, they used to cause Parkinson-like side effects, which used to look ugly, but metabolically it was better. Now the Parkinsonian side effect is not there for the new medicines, but they cause accelerated weight gain. So medicines become a very important cause. The brain active, all the psychotropic and neurotropic medicines, weight gain becomes a very, very difficult problem with all these medicines. Just a repetition to strengthen this basic mechanism is neuroinflammation. And inflammation comes from two sources, as this diagram shows, from the gut and from the adipose tissue itself. And the inflammation basically damages the brain. It irritates the brain. These are typically, as I said, what we otherwise see in dementia-like states, the white matter changes which are happening because of the allostatic load and because of the inflammation. So what therefore happens is that although the disturbance may start in any of these components, finally it spills over onto the whole system. And therefore now we have this idea that all NCDs are basically systemic disorders. Although in the history of medicine, they were divided across different specialities, but essentially they all sort of share a common substrate. This whole field called as DOHAT, maybe you may be aware of this acronym, Developmental Origins of Health and Disease, which tracks that what happens during pregnancy, what happens during the early childhood. So the negative events happening during that time, they have a very significant effect on the adult life. So childhood adversity, childhood trauma, we speak more about it in the evening when we have the mind-body crosstalk workshop. So very important therefore risk factor, because at that time, as you know, that during the infancy, during the toddler state, the entire autonomic and endocrine and immune axis is still developing. And the stress affects it in a sort of a permanent way, like a permanent scar. And one of the important consequences of it is a lifelong risk of obesity and the whole spectrum of cardiometabolic disease and comorbid, of course, with all the psychiatric disorders. I spoke about the role of amygdala in adiposity. It's a very interesting line of research from the childhood trauma. That children who undergo trauma, their amygdala, what happens is it follows a completely different developmental track. It sort of precautiously develops and then it burns out. Okay, therefore, setting the entire brain in a, you can say, abnormal way, people try to now even trace it back, to what happens. So, if the mother is obese, so not just the genetic part, but also the epigenetic part, maternal adversity. So, not just the maternal genes, but even the maternal adversity also, how intergenerationally it translates in the form of obesity and leads to a lifelong fetal programming, towards that. So, effectively, what we essentially are looking at for the long term management, I'm not talking of short term management of NCDs or short term management of obesity. Long term of management of obesity, it is imperative, that we have to rewire the brain networks. So there is a abnormal wiring in the brain, you can say, in all the non communicable diseases, and which needs to be rewired. And that rewiring, we have, of course, pharmacotherapeutic options, and those pharmacotherapeutic options need to be supplemented by the non-pharmacotherapeutic approaches, about which we are, of course, going to talk over the course of next 4 days. But this is a very important task of rewiring the brain. That's why I put it out there, that unless the brain is rewired, as on other terms, it's also called as a neuroplasticity. Brain is plastic. Every organ in the body is plastic. Bone is plastic, brain is plastic. Every tissue practically in the body can be changed. So unless we voluntarily, deliberately make effort, to rewire the brain, the effects are not going to stick. So somewhere therefore we have to understand that we currently, whatever tools which are available to us, the pharmacotherapeutic tools as well as the various non-pharmacotherapeutic interventions, that in addition to doing many other things, what we do, so that we are able to rewire the brain and set it to a normal brain. In other words, it is not only the neurological patients or psychiatric patients who have abnormal brain state. All NCD patients actually have abnormal brain state. Brain is a very important, target, which must be sort of rewired if we have to have a long-term benefit. As Vaishali madam said, many of these discussions have been summarized as part of this position statement, and RSSDI was very kind enough to set up a task force last year. A good part is that the various authors who are listed here, you are going to listen to all of them, during this particular event. So Vaishali Deshmukh is there, Sanjay Phadke is there, Sanjay Agarwal also, I think you are going to listen to him. And Leena Phadke is already here. Shivram is also going to speak, and so also other people, from this group. So that is what we sort of look forward to. And my central theme message is that when you talk of obesity, when you talk of NCDs, please also remember, that brain is a very important stakeholder in that. Thank you so much.
Thank you, Phadke sir, for the insightful and enriching talk. Now we invite Dr. Kavita Krishna, Professor and Head of the Department of Clinical Immunology and Rheumatology at Bharati Vidyapeeth Medical College, Pune, founder and president at the WHIRA, and has over 140 publications.
Good morning, everyone. So thank you, Dr. Vaishali, Dr. Phadke sir, ma'am, for inviting me today. I was a part of last SYNAPSE also, but that part of it was online, and then we had the physical sessions. So I'm not here to make any claims because I'm a rheumatologist. For rheumatologists, obesity is there, but we are just trying to connect the dots. And at the same time, we have to understand that in the last 2 decades or so, the paradigm is shifting from communicable to non-communicable diseases. So the topic that has been given to me is obesity is an immunological disease. We have seen how it's a connection between the nervous system, the endocrine system, etc. But there's a lot of inflammation, as Dr. Vaishali already said. So let us see what this inflammation is about. But what is translational for us as rheumatologists? What is the connection? And how the new medications that are coming along are giving us the immunometabolism and the incretin revolution that is coming into immunology or rheumatology. The first part, of course, is immunology of obesity. The new term that is being used nowadays is meta-inflammation. That is one term we need to understand when you talk about adiposopathy. That is the adipose tissue. But the adipose tissue in an obese and a lean person is different. So meta-inflammation is a state of chronic inflammation, inflammatory state, which is chronic, low grade, non-infectious. Okay, the whatever processes are occurring are not related to any infectious organisms, but there is a lot of immune infiltration into these cells. So for decades we thought obesity is just calorie in and that is exceeding the calorie out. But it's time we re-looked at the pathogenesis of obesity. It is a multi-system problem. So whenever they have studied the lean cell and the obese cell, so these cells are different in content and the function also. So the 2-3 terms I'm going to use again and again. One is the M2 macrophage, the Th2. Okay, so M2 macrophage is a stable lean cell. This takes care that we have no inflammation. It's anti-inflammatory. So also Th2. And the B cell IgM gives us good antibodies. So this is the status in a lean cell, okay, lean immune cell. What happens when the person becomes obese? This is an obese cell where you have M1 macrophage, you have Th1, you have B cell IgG. So what do all these cells do? They cause inflammation. So the left hand side is anti-inflammatory, the right hand side is pro-inflammatory. Let us see in detail how this happens. So there are 3 stages. Initiation. So a lean, healthy cell is robust, metabolically healthy and active. So you have lean adipocytes, which are normal in size, and as a result, they have M2 macrophages, which are anti-inflammatory. We have T-regulatory Th2 cells and a low leptin. Low leptin is good as an anti-inflammatory. What happens when the cell becomes obese? The trigger is, of course, initially increased nutrition, increase in diet. That is a trigger. So the cell becomes larger. Okay. So when this hypertrophic adipocyte starts off, so this becomes large. The blood supply is not enough, so it gets hypoxic. So the moment it gets hypoxic, along with the free fatty acids, you're going to get DAMPs. DAMPs are damage-associated molecular patterns. So these are the ones which trigger an inflammatory cascade. What happens further? And as I said, M2 becomes M1, Treg and Th2 becomes T1. If you remember this, you'll understand that is the basic pathogenesis of meta-inflammation. So the stage 2 is amplification. Whatever started is going to get amplified and is going to spread elsewhere. So what happens with the macrophage? Macrophages are basically monocytes. So M2 transits to M1, as I said. There's a recruitment. More and more M2 macrophages become M1. Then this is innate immunity, the basic immunity that we have. Then there's an adaptive immunity where the T cells come in. So these T cells also, the regulatory and the Th2 become less and these become higher, the Th1. And there's immune fire, so to say, the inflammation sets in. And then there are whole lots of processes. There are deeper molecular processes inside the adipose cell, and that is called NLP3R3, that is inflammasome. Just remember the word inflammasome. And there are a lot of activation here. A lot of interleukins, a lot of cytokines are released, TNF alpha, interferon gamma, IL-18, etc. And this is the downstream. What happens in the end? There's inflammation, there's insulin resistance, which you all know about, and there's endothelial dysfunction at the levels of the arteries, blood vessels, etc. So what is the systemic impact? That is what happens to the patient. Because of all this, what you get is cardiometabolic disease. You have all these interleukins. It affects the liver, the muscle, the blood vessels, and this is what you get. Beta-inflammation, insulin resistance, and cardiometabolic disease, which you all know about in all the trials that have been done, how reducing obesity reduces the inflammation, and that is why it improves the cardiac outcome. It reduces the cardiovascular mortality. So just checking, revising what we all said, the adipose tissue has become large, it becomes hypoxic, it can't breathe. So the innate system first comes in, the M2 becomes M1, TH2 becomes TH1, and all the inflammatory process starts in, that is the meta-inflammation. And then this is a stay in the adipose cell. It spills over. It goes to all the systems. It goes to the portal circulation. It goes to the heart, the muscle, the liver, and all these cytokines are released. And it is these cytokines which are causing damage. And that is where one of our rheumatic diseases also come in, because most of our rheumatic diseases are cytokine driven. So it spreads and damages all the body. That is why obesity is connecting the dots. You've got different diseases, all are connected some way or the other. So where do we come in? Why are we interested in obesity? Half of our patients are obese and some are not. Okay, but wherever it is, the incretins, that is your GLP-1 receptor Ozempic, what everybody is talking about, they say GLP-1 receptor analogs work everywhere, they work for everything, they improve all diseases. But what is the basis behind all this? Let us see some of them, how they're relevant to us. So there have been a lot of trials, a lot of studies to see how GLP-1 receptor agonists can help us in rheumatic diseases, or what we call now is metabolic immunomodulation. Or at least we can optimize the immunological system. So all these GLP-1 receptor analogs which came right from 2006, you had exenatide, and now we have semaglutide and the dual and the triple agonists which are coming in, which are being used for everything, including obstructive sleep apnea, fatty liver, and everything. Okay, so just a little quiz for you here. The first one was exenatide. Any idea where this came from? Gilaman, you're not supposed to answer. Okay, yeah. So this is a big Mexican lizard, okay, southwest US desert. It eats only 3 to 4 times a year, and its saliva contains exentin 4. So when they're trying to manufacture this somewhere in, I think, Washington or wherever, they couldn't do it. And actually they brought this lizard all the way to the labs, and they found that this particular venomous lizard saliva has led to a multi-billion-dollar business for the entire world. And this is good to know as a general knowledge question, the Gila monster. Coming back to our topic, so the distribution of this GLP-1 receptor agonist is the basis for our thinking and what we are putting up the hypothesis, how it can help us beyond traditional glucose and obesity treatment. Probably it has a role in rheumatic diseases also. So GLP-1 receptors are there everywhere. This has been shown in the animal models, in vitro studies, in trials. It is there in all the immune cells. So that is how it can help us. These agonists have anti-inflammatory effects in different experimental models. And what they have found, that because these receptors are highly expressed on these cells, in macrophages and on T cells, they can reduce all these signals which cause inflammation. NFK beta signaling, NLRP3 inflammasome, pro-inflammatory cytokines. So it reduces all this. It also reduces the T cell activation, Th1 responses, and it increases our regulatory T2 cells. Okay, so all these are cytokine coolers. Whatever cytokines are built up in the body of a rheumatic disease or an autoinflammatory disease, they probably cool it down, and that goes beyond the weight loss or the blood sugar control. So while GLP-1 analogs reduce inflammation, improve insulin sensitivity, improve quality of life, probably it also causes better outcomes in some of the autoimmune diseases. So what is the problem with our DMARDs? We are treating our disease already, but sometimes they are not enough. We need to take a holistic look at our patients also. So we now need to see what are the metabolism abnormality that is driving these diseases. So there we have to see whether it has a role. And there are enough trials to demonstrate this. So I'll just go briefly over the common diseases that we see. So first of all, psoriatic arthritis. This looks like a very busy slide. But in the last ACR, which I attended in the US in 2025, and studies are going on. So in the US, they have access to a lot of data, TriNet X, etc., where they analyze lots and lots of patients. So you have, supposing, 2 groups of patients of psoriatic arthritis. So in this, if you see, I'm sorry if it's a very busy slide, but there were about, there were patients, there were two groups. One group was on GLP-1 receptor analogs, not for psoriatic arthritis. They were on these drugs for obesity or for diabetes, etc. And another group was not. They were on some other medications. So there were 4,000 patients who were on GLP-1 receptor analogs and 86,000 who were not. So what they in short found that the ones who were obese and were on these medications, they had a weight reduction. But if you did a propensity analysis, you removed the confounding data, still the psoriatic arthritis got better. There may be multiple reasons for that. Because of weight loss, the drug worked better, or there's an inflammation angle over there. And overall, what they found, well, the psoriatic arthritis also, who were on GLP-1 receptor analogs, they had better outcome, less cardiovascular mortality, less risks, etc., as compared to non-users. So the drugs help in reducing obesity, reducing psoriatic arthritis inflammation, improving outcomes from there. And the ones who were on these drugs had lesser prevalence of psoriatic arthritis, both ways. So this is all retrospective data analyzed later. But probably, definitely, there is a role. So if a psoriatic arthritis is obese, it's worth treating them with GLP-1 receptor analogs. What about osteoarthritis? Osteoarthritis by far is the most common rheumatic disease associated with obesity, and majority of our patients are obese. Though it's common sense to say, okay, because the patient is obese, there's metabolic load, and that is why the joints are overloaded, and that is why there is pain. But what I've seen, there's a lot of research on this. It's not just the weight that causes pain, there's also inflammation. Just like you have GLP-1 receptor analogs, the leptin and the other cells, they also present in the chondrocytes and the cells around the knee joint. And that is where also you have adipokines, cytokines, DAMPs over there also. So there is an inflammatory component also of the osteoarthritis, and that is why there is probably some role of GLP-1 receptor analogs there. And actually, pain in osteoarthritis is a continuum. It's not just pain, just localized pain. There is leptin over there, which is increased. There is substance P. There is a neuromediator. There's nociceptic pain receptors, etc. The neurological component of the pain is also connected over here. So what is found is GLP-1 receptor analogs may have a role here by reducing obesity also, and some other aspects also. And what in experiments they have found is that it inhibits the MMP3, MMP13 and ADAMTS, and this causes less of cartilage degradation. Okay, so it reduces the cartilage loss. So there were two good papers which demonstrated this. One was they took about 1360 patients of osteoarthritis who were on semaglutide, and 39,000 patients were not on semaglutide for their obesity or diabetes, etc. So it was found that osteoarthritis risk was probably reduced. They have claimed 16%. Now, there are multiple, of course, limitations of these trials. I'll just show you the other trial also. This is a famous Step 9 trial. It was published in the NEJM, which is a very reputed medical journal. So here they enrolled 407 patients with a high BMI, and there's a WOMAC pain score, which is for osteoarthritis, and they found a significant reduction in the WOMAC pain score in these patients who were in GLP-1 receptor analogs. So both these trials showed that there is definitely a role of GLP-1 receptor analogs in obese osteoarthritis. They have not studied the lean osteoarthritis. We have also got post-traumatic A, we have thin patients of osteoarthritis. So we don't know there. Secondly, though they say it was double-blind, it may not be really double-blind in the true sense, because the patient is going to lose weight a lot. They know they are on the drug. So there must be a psychological aspect also. The third thing is that this is, as I said, it is not studied in the lean osteoarthritis patients, and it is only clinical. They did not do any objective MRI and all to show that this was really improving. And they did not do it in grade 1 or grade 4 OA. They did it only in the grade 2 and grade 3 osteoarthritis. But yet, it is worth remembering this. Then we have our lupus nephritis. Some of them, the proteinuria doesn't get better at all. So there was this study by Grabowski et al., where they studied, again, they were lupus patients on GLP-1 receptor analogs for diabetes or obesity, and they found there was a definite improvement in the proteinuria. What happens in lupus, many a times you don't know what else to give. So if the patients are obese and having a high blood sugar, probably it's another option, where it's shown that it improves the podocytes, it causes some anti-inflammatory effects. So this data was quite promising. Then I think about the gut and GLP-1 already Vaishali has spoken about, but there is definitely some action that is going on at the GLP-1 level in the gut also. It has a good effect. So probably a role in our IBD related arthritis also. And rheumatoid arthritis and psoriatic, it is just observation. There's not very great data here. So beyond obesity, GLP-1 definitely has a role. And this is a metabolic shield. There's renal and cardio protection. There is probably some microbiome connection. And obesity is a risk. There's a lot of meta-inflammation that is happening. If we tackle that well, maybe we can treat our patients more holistically. And we definitely have to enter a immunometabolic optimization stage. We should shift our goals beyond the tender and swollen joints. And we have to understand there is a hypoxic adipocyte, there is an M1 macrophage, there are Th1 and there are cytokines. So all this definitely is there. And if we treat the weight and the obesity and this inflammation, probably we will have a better outcome. So if we choose our patients correctly, some of the patients we treat the obesity, our outcome in our patients may be better because obesity is an immunological disease. And if we treat this, definitely our outcome can be better. That's my department at Bharati Vidyapeeth. Thank you.
Now we have Dr. Arvind Chopra, one of India's senior rheumatologists and a respected physician in the field of rheumatology. We invite him to share his expert insights on the same, obesity as an immunologic disease.
Hi, good morning. Thank you for calling me over this morning. As I was coming up, Vishali said, "Oh, you will write a lot of semaglutide." I said, "Not me." So lovely to be here. I think I'm out of Pune. It took ages to reach here. I'm not going to talk anything. I'll try not to talk about treatment, which has been covered very nicely by my colleague Kavita. And believe me, this is a mess. This subject is a mess. And we need to find our way through it, depending on what kind of specialty we are from. And unlike my friend Dr. Fadke, I do not claim any stake in this subject. Let me be upfront. In fact, some of my worst patients are the obese patients with the inflammatory arthritis. I really dread them, actually. I really don't know where to start. I really don't know where to start my palpation, actually. They're the most difficult patients. So congratulations, Shali, for getting everyone together to solve this problem. And so let me be a little offbeat, stray thoughts. Maybe they'll provoke some of you. Where do I start? Okay, I hope you can see these slides. Now, of late, or let's say not late, actually for 30 years, honestly, but last 10 years have been exciting. We have this global burden of disease project. You must have heard of it, Institute of Health Metric Evaluation from USA, along with WHO, they got together. And for the last 3 decades, they've been teaching the world what kind of global burden of disease they are, right? You must have seen those reports. They come sequentially every few years in Lancet. In fact, I don't know whether they have bought over the Lancet or Lancet has bought them, but that's where they come. There are a lot of fallacies and a lot of caveats, and there are a lot of problems with that, what the data is actually, but I don't have time to go through that, maybe some other day. What I'm trying to tell you is that I've been hearing from friends like Vaishali and from India is the diabetes capital of the world. You all agree, right? You all know that, right? It's not so bad, by the way. Now, that slide on top, which I pointer is not working, that one. You know, the color code, the more you're towards red, more are you contributing as a disease burden in the world. Well, India is still light blue, and there are countries where it's yellow. So there are many other countries that got more diabetes than us, actually. But the numbers matter, maybe because of population aging. But look at the slide on the right, which I think is more important, this one. Now, this is very latest. These are new data, actually. Those belong to 21. India is number 1 when it comes to body mass index, contributing to the DALY, disease-adjusted life year, disease burden. I think this is more important because when you talk of preventive medicine, this is where you get the BMI. And with BMI, you're talking about metabolic syndromes. So the picture is bigger. You have a concept. Yes, India is the capital. You can see how red we are. Literally, we are bursting. There are some other countries sharing with us also. But just to give you a picture as to where we are. I'm not going to be reading my slides because I just have 10 minutes to finish up all this. So please go along and read it. Of course, as a rheumatologist, it is RA which excites us actually, because most of our patients in the OPD are patients with rheumatoid arthritis, and there are real challenges. What I'm going to try to tell you is that when you look at the data, this was very elegant data. In fact, this is a very impressive paper. I've never seen a paper with 1,289 references. I don't know how they worked so hard, and it's a very beautiful paper. But I'm not going to go through all what I've written, but that red circle says that yes, in this particular paper, they looked at their own data in the hospital, so their actual data, and they reviewed the subject. So that's important. So you can see what the situation is as far as diabetes and all is concerned. This is our very own data, very fresh, not yet published. We are doing a lot of epidemiological studies for the last 30 years under a banner called WHO COPCOD. And some of you might have read those papers, Community-Oriented Program for Control of Mad Disease. We started that in a village called Bigwan, which is not very far now, 100 kilometers from here, on the world map of migration of flamingos, but also on the world map of Chopra. If you see that, you'll find Chopra coming along with flamingos. So there's a lot of data from there, but this is a survey which we repeated a few years back, 25 years after working in the village. That's not my target this morning, but we have analyzed the data, and you find that hypertension and diabetes are important risk factors for all people in this village who reported past or current musculoskeletal pain. Now, I'm not talking about inflammatory, the entire gamut of MSK. And this is well known. In fact, MSK pain, chronic MSK pain, is twice prone to have a comorbid disorder. And amongst the leading disorders are hypertension, diabetes, and obesity. Of course, I hate to call obesity a disorder. What would life be without good food? I don't understand. So a little bit of obesity is all right. Vishali, don't feel bad. Okay, so again, just going off the GLP, because I think this conference is going to be bombarded by GLP-1. There are some other stakeholders also in this whole process. And I am fascinated by the so-called cellular stress. I think, going down absolutely. And again, this subject sort of, I'd say it's a mess. When you think this is upstream, then you find, no, there's something above that. So there's no upstream and downstream events from immunology point of view in this subject. Everything is a circle. It's a really, like my friend said, egg and chicken story, actually. And that's what you must keep in mind. So I put some nice big circles to show you. Now, I agreed that we're talking about meta-inflammation or met-inflammation. And I thank Vishali for last year introducing allostasis. I never knew much about it, honestly. I read after I saw your program, and I said, what the hell is this? All I knew is physiological adaptation. But metastasis ka baap hai. Allostasis is a consequence of meta-inflammation. It's a physiological response to that. Please remember, some of these basic concepts are important. And there you are. We all here together because of that, neuroendocrine system, distress, metabolic, homeostatic disorder. That's what brings us all together. Okay, good. So as I said, please learn. I'm learning that the so-called cellular stress in our good old MBBS days, homeostasis, milieu interior, we were not aware that the poor cell goes through so many shocks, actually. And each one of them is important, but the first three on the top, to me, at the moment, are most important to remember when you try to connect the dots. And I'm going to talk a little bit more about that, so let's move ahead. And I want to remember, God has given us nothing for disease. Please remember this basic concept. You play with physiology, you play with fire. And that's what possibly rheumatology we have learned very, very, I would say, it took us time to understand. It's not that cytokines, all that cytokines, And whether you talk, any of those physiological systems that you read, all are for health. So one has to understand when there's a breakdown as to what level we are intervening. So that's very fundamental thing to remember, and that's where all the adverse events comes in. That's where all the disorders come in. We have no idea as to what are we actually inducing in a patient while treating his disease with so-called biologic or very target drugs. And that's a basic thing. Okay, so let's move quickly fast. I asked Vaishali, what do you want me to talk? She said, I wanted to bring in immunology, but we don't have time, Vaishali. Maybe we'll have a session some other time. There's so much immunology, but from my point of view, what's important is that whether there's obesity, whether there's diabetes, whether there's any of these, all these toxins getting together, whether you call them cytokines or prostaglandins or leukotrienes or all those hundreds of them, all these short-chain fatty acids, this, that, all of them, they play havoc with the immune system because human system doesn't belong to rheumatologists or immunologists. That's in every disease. So actually, there's so many receptors in the cell membrane which actually sort of, I would say, get under so-called stress. But from my point of view, to put it very simply across to you all, the basic immunology is all the immune cells get reprogrammed. Like my friend was saying, rewiring, but this is reprogrammed in an adverse manner. The T cells, B cells, they all go sort of almost like they go mad actually. Intracellular signaling, everything was havoc. The macrophages from M2 becomes M1. They become sort of, pro-inflammatory. And everything, whether it's gut, everything, etc., it disturbs the entire system. And as you can see, so many things are out there which you might have seen by now. And here, the most important part of this particular slide is what I put in yellow. There's a functional partnership between Kavita and me. It's not only GLP. To me, in fact, the insulin resistance is more fascinating. Both are core issues. Please connect the dots later on, but these are two important issues. And in fact, I had a so not peep into Kavita. I asked her very, cunningly, what are you going to talking about? I knew GLP. Oh, I said, thank God, she's not going to talk about insulin resistance. And I never told her, I didn't want to tell her I will talk about that. I need to talk about something. To me, this is the crux. Believe me. And as a rheumatologist, I've begun to understand what insulin resistance is all about. I agree that GLP-1 is proximal, it's upstream. Receptor, it's got a receptor of its own. And then there's insulin receptor. But they can not only they affect each other, but they work together also. They've got a direct connection when it works. Okay, let's skip. This is very fascinating to us, actually, and this was a very important paper in Arthritis Rheumatology, which is one of our big journals. This was published quite some time back, and it taught us that so-called insulin resistance or low insulin sensitivity seems to be at a core issue with rheumatoid arthritis. In fact, these people went ahead, I think there's another paper maybe, to say that low insulin, I think it was a huge study called NHANES. These surveys come in from the United States every few years. Health exam, you must have seen them. They're very fascinating surveys. Nutrition, self-reporting. They said that it seems that low insulin sensitivity actually makes people susceptible to rheumatoid arthritis. This was a hypothesis which is generated. In fact, they also said, I think maybe having something more on this, that even the rheumatoid factor positivity seems to be connected with insulin resistance. Something very basic, something at a very core level. And okay, let's forget about that. So as I said, in the next 2-3 minutes, I'm going to sort of almost, overwhelm you with insulin resistance. I think we need to be solving that too. Of course, GLP-1, when you have an agonist working on it, it does improve glucose homeostasis, all that, etc., etc. And maybe it also very strongly improves the insulin sensitivity with so many other things. But that itself becomes a target. Insulin sensitivity improves just by reduction in weight, meditation, exercise. So you don't have to give them many drugs if you can do this. But who has the time to do all this? So we want drugs. Okay, so and from rheumatology point of view, it's not only the cytokines. We were fascinated by the so-called biological drugs. You all have heard anti-TNF, anti-interleukin. So many of them we have been using. I want rituximab. But even the new one which we got, target synthetic DMARD, which is a JAK inhibitor, which you all know, tafasitamab. So many of them are in the market today also. It's another family of drugs we are getting. Even the JAK stat mechanism is the one which gets implicated when you talk of insulin resistance. And I think that's important also. So let's skip all this. As I said, I'm going to leave you so much more confused than what you were 10 minutes ago, but remember that. So then there's something called lipid paradox. Now, what the hell is lipid paradox? Anybody? Except for the first branches, maybe the first branches can be included also. Now, this was a very, very peculiar thing. In rheumatoid arthritis, a very active it's a metabolic disease, not an immunological disease. And for some reason, even when your LDLs are low or the lipids are low, but the cardiac complications keep increasing unless you control the disease. Now, that was something very peculiar, very difficult to understand. Lipids are low, and yet the patients can get progressive atherosclerosis, all the cardiovascular problems I think of. That is what the paradox was, because it was felt that it's not only the low lipids, but the atherogenic lipids are more important. And when you look at insulin resistance and all what we're talking about, that gets sorted out. Okay, so I'm finished my 10 minutes, I think now. Let's forget about the gut. We are going to fill up the gut come what may, isn't it? Come what may. Let it leak as much as it wants. But it's important, the gut microbiome and all that. But it's so, I'm fascinated. We talk about gut microbiome. The Ayurvedic people knew 5,000 years back. Do you realize that? Because the entire Ayurvedic management of arthritis is centered around gut. जाओ उसे उल्टी कराओ, जाओ उसको डायरिया दो, जाओ उसको ये करो, वो करो. It's all the gut. And that's how people get better. They knew about it. And we are talking about microbiome. So they had many, many other things. Anyway, it's okay. Okay, let me finish now this. As I said, things were pretty bad, actually, because we were trying to, it's like an elephant, sir. Dr. Fatke, we is elephant. You're holding maybe the trunk, I'm holding the tail. It depends what part of the elephant you're groping, actually, isn't it? So there were so many problems. And definition of metabolic syndrome itself is very interesting. Please read about it, how this whole metabolic syndrome has evolved. But what fascinates me now is that out of all the five, I think the five criteria for metabolic syndrome that we talk about, I won't go into, the sixth one has got added. Uric acid. Now, these people, this was just again a serendipitous kind of looking at the data. The people who spend their entire life looking at the data only, the data bugs actually, maybe of higher evolution than cockroaches. That is what they are, data bugs. And they come up with nice sort of revelations. They said that if you have a metabolic syndrome defined by five things, MBMI, systolic hypertension, diabetes, lipids, those five things, if you add the people with hyperuricemia to it, it adds 15% to the so-called outcome measures of cardiovascular, and therefore they said uric acid should be combined. Uric acid should be looked upon as a metabolic risk. To a rheumatologist, that's very fascinating, because we deal with uric acid, uric acid. But let me finish up something. I think this may be the last slide. Oh. Now, I grew up, I think, Kavita, you must listen to this, because you were born much later. Okay, so when I was doing my MBBS MD, and I was going through rheumatology, there was something very fundamental in rheumatology textbooks, which I remember very clearly, and I was fascinated by it. Rheumatoid arthritis and gout hardly ever come together. Socho. Kavita. Rheumatoid arthritis and gout hardly ever come together. Hardly ever. This was obsession for a long, long time. Tum dekh lo. Those of you are in, I'm sure in any practice, have you heard of it? It's very uncommon. When I was doing MD, I was going to the literature. I said, why? Because in any population, one disease is there, another disease is there, prevalence, multiply by 2, you get a common, this is epidemiology. But yet this particular partnership beats. I don't have any answers to it, but then those rheumatologists, those days, there was one explanation given which was followed for quite some time, that high uric acid is anti-inflammatory. This was written in Copeman's textbook, which is something like one of the archivals. I said, okay. So I was following that track till this paper I read about your uric acid being combined. If uric acid is combined to the metabolic, it's inflammatory. But uric acid has been thought to be anti-inflammatory in many, many ways too. Gout is inflammatory, inflammation, all that is fine. But obviously we are wrong. The coexistence uncommon, we do not know. But I don't know, maybe next time I'll try to answer. But the fact is that gout and rheumatoid arthritis rarely come together. Thank you very much.
Thank you so much, sir. That was truly enriching. Now, our next speaker is Dr. Nikhil Gupta, founder and senior consultant psychiatrist at Mind Wellness Clinic, Jammu, co-chairperson of Mind Body Medicine Specialty Section IAPP, and an expert in integrative psychiatry with over 12 years of clinical experience.
Speaking about psychology of eating behavior, the outline will be we will talk about it, and we will be talking about understanding eating behavior, its normal regulation, the various psychological uh, mechanisms and models, and the continuum of normal eating to disordered eating, and the comparison between binge eating disorder and night eating disorder. So I will be talking about a case. A 32-year-old woman presents with weight gain, low mood, and poor sleep. She reports that following stressful arguments with her husband, she experiences an intense urge to eat late at night. She states eating helps her relax and fall back asleep. She is aware of these episodes. She feels unable to resist the urge and often experiences guilt afterwards. What drives this behavior? Is it hunger alone or the psychology? Eating behavior is the result of a complex interaction between biological needs, reward pathways, emotional states, cognitive control, learning, and social and environmental cues. Food choice is driven by far more than hunger alone. We engage in eating behavior every day. One has to make choices what, when, and how much to eat, while our ancestors' primary task was to seek out food. Food choices have been increasingly complex nowadays. Food is engineered, it's easily available, it's abundant, and it's so accessible. Learning shapes our eating behavior, and these are the mechanisms that we will be covering in short. This classical conditioning model shows us when we repeatedly pair an unconditional stimulus like food with a neutral stimulus like television, it we can have conditioned response like salivation even in the absence of food. The operant conditioning model tells us that repeated pairing of food with emotional states like sadness can cause lifelong associations, making food a coping mechanism for psychological distress. Learning shapes eating behavior, and these are critical in the development of young children's eating behavior, which may carry over into the adulthood as well. Behaviors associated with escape from distress or a positive response state lead to functional and structural brain changes. Dopamine mediates reward, motivation, and reinforcement, increasing likelihood of repeated eating. Most often, beginning in the adolescent, eating behaviors are strongly correlated with early childhood trauma, neglect, and disordered attachments. This pathway shows how early trauma attachment disruptions can lead to emotional dysregulation, which may, for an individual might seek food as a soothing behavior and may lead to disordered eating. Normal eating requires hunger regulation, satiety recognition, executive control, and reward modulation. Healthy eating requires continuous self regulation to balance psychological needs with environmental temptations and reward driven eating without losing control. This homeostatic regulation of eating is challenged and overridden by the omnipresence of food. Thus, eating can be triggered in the absence of hunger or extended beyond satiation. Homeostatic eating, that is our need to eat for energy and maintain energy balance and adequate nutrition, whereas hedonic eating is our want to eat, that is pleasure eating, and triggered by cravings or psychological states and emotional situations. Highly palatable foods become specially rewarding during emotional states. Targeted marketing, temptation, and immediate gratification promote hedonic eating and may contribute to binge episodes. We keep on getting these notifications from the food delivery apps, which shifts which shifts control from homeostatic eating, which shifts our control from homeostatic eating to hedonic eating. Eating in response to emotional states rather than physiological hunger is known as emotional eating. Stress activates the HPA axis and increasing cortisol and preferences for comfort foods. Temporary relief reinforces the behavior, increasing future emotional eating. While some of us will experience overregulation of eating behavior, resulting in underweight and malnutrition, whereas on the other side of the extreme, underregulation or permanent failure may result in overweight and obesity. Healthy eating depends on executive functions such as self control, planning, and cognitive regulation, whereas stress and negative cognitions weaken these abilities and increasing our impulsivity for food choices. This slide sums up all the psychological factors that can influence eating behavior like stress, anxiety, depression, dietary restraints and perfectionism, conditioning, habits, reinforcement, personality traits like impulsivity and low self-esteem. Friends, family, culture, celebration, the social isolation, and the advertising, and easy access to ready to eat calories around can increase cravings and emotional eating. Interoception, our ability to perceive internal body signals such as hunger and satiety, influences eating behavior. We need to know what emotions we are feeling in order to regulate it. And so the emotional vocabulary becomes very important. Poor interoceptive awareness may lead to misinterpret emotional distress as hunger. Eating disorders are associated with common psychological patterns, as eating begins as a solution to otherwise unmanageable emotional states, external conditions due to unprocessed memories, and developmental deficits, which impact one's ability to self regulate emotions, thoughts, and sensations, pushing eating behavior. This behavioral model tells us that how negative cognitions like I am a failure can make someone feel negative emotions which may induce some food cravings and can pull a person to binge, which will temporarily relieve those feelings, and then the person may have guilt about the binge, so he further restricts his diet, and a vicious cycle of more craving and next binge keeps on going. Once a cycle is established, addictive behavior is habituated and control over use is lost. This trices model from the EMDR therapy, it tells us that any experience or an event generally get processed, or we feel that processing in terms of memory, thoughts, emotions, and body sensations. And any complex interplay or so-called not so proper processing of these parameters can lead to a maladaptive or a disordered behavior. Repeated activation creates rigid maladaptive eating behavior. These behaviors negatively impact the core sense of self and social connectedness, and sometimes they are referred as maladaptive attachment styles. Over time, this develops into a rigid pattern of response. Emotionally charged memories of initial relief and euphoric call pull the individual toward their chosen solution in the form of cravings. This 4P psychological formulation actually enumerates all the factors that makes us vulnerable, that can towards eating behavior, that triggers or maintains or recovers or might influence the recovery in terms of disordered or the maladaptive eating behavior. This article provides an excellent overview of the psychological mechanisms underlying eating behavior, and it places psychology disorders such as binge eating disorder and night eating disorder within a continuum of eating behaviors rather than as isolated conditions. So, this review helps us to put uh, normal eating and the disordered eating on a continuum from healthy eat, from adaptive eating to maladaptive, from healthy eating to eating disorders, rather than understanding or trying to look at them in isolation. So accordingly, it has been recognized that eating behaviors can be mapped onto a continuum ranging from normal to disordered eating. And the same psychological processes operate across healthy and disordered ends. We can look at all the eating disorders as a continuum, an array of eating behaviors that do not reflect disordered eating per se, but nonetheless seem to be associated with occasional overeating and moderate overweight, restrained or emotional eating. So generally, it is not supposed to be disordered eating only, but an occasional overeating and moderate overweight is also kept on the continuum from adaptive to maladaptive. So a person may have signs like eating until uncomfortably full, eating to ease their own emotional states, recording their weight repeatedly, consuming excessive amounts of food in short period, feeling desperate to control eating and lose weight, associated with emotions of guilt, disgust, and depression. This can be this can be a binge or a binge eating disorder. So the American Psychiatric Association in DSM-5 defines binge eating disorder as consuming large amount of food over a discrete period of time with a sense of lack of control over eating and marked with significant distress. And the diagnostic criteria is recurrent binge episodes, consuming large amount of food, loss of control over eating episodes, marked distress without any compensatory mechanism like vomiting or laxative use, and one or more than one binge per week for at least 3 months. The associated psychological factors are shame. Most common associated factors are shame, restriction, emotional dysregulation, and negative self beliefs. This slide shows us the evolving definitions and addition to the concept of night eating disorder or syndrome, which was first explained by Stunkard in 1955 and was characterized by evening hyperphagia, morning anorexia, and insomnia. It is characterized by a delayed circadian pattern of food intake where there is a consumption of more than 25% of daily calories after the evening meal. In the recent DSM, it is classified as OSFED. Other specified feeding and eating disorders, the core feature remains evening hypophagia, nocturnal eating, morning anorexia, insomnia, awareness during these eating episodes associated with significant distress. And, and a person may tell us that I need to eat or I need to be uncomfortably full before I can fall asleep. Eating becomes a learned sleep associated behavior. In binge eating disorder, it is possible that there are nighttime awakenings with food intake, but these are not as characteristic as in night eating disorder. The amount of food consumed during binges is significantly greater and higher as compared to the night eating syndrome, which differentiates both of these diagnostic entities. Whereas in night eating syndrome, there is impulsivity related to the food intake in the evening. There is need to contain the present anxiety using food in a compensatory way, the development of sleep related rituals, and the desire for food, the characteristic of a real craving. This table helps us differentiating binge eating disorder and night eating disorder, which may otherwise look same. In a binge eating disorder, the episode of binge can happen anytime, whereas the night eating syndrome, the binge or the repeated eating episodes are mostly in the evenings, or they start after evening. In a binge eating disorder, there is loss of control over the binge, whereas it is not a characteristic for night eating syndrome, which a person is mostly conscious of the eating episodes. In binge eating disorder, the amount consumed is large, whereas in night eating syndrome, there are smaller repeated eatings up to till a person can fall asleep. Binge eating disorder is generally unaffected by the sleep, whereas sleep is mostly disturbed in the night eating syndrome. Morning appetite is usually normal in a binge eating disorder, whereas a person does not feel like eating in the morning if he has night eating syndrome. Uh, Binge eating is independent of the circadian relationship, whereas night eating has a significant relationship with the circadian rhythm. Mostly the reason for eating in a binge eating disorder is emotional distress with loss of control. And for night eating syndrome, it is mostly a coping mechanism to reduce anxiety, stress, loneliness, or to facilitate sleep. And mostly to facilitate sleep. To sum it all, the psychology of eating behavior, what we have talked about till now is how some vulnerable cognitions, emotional states, or negative thoughts can trigger a person, can make can trigger some emotional discomfort in the person in which he takes food as a self-soothing way and can promote maladaptive eating behavior and then may lead to eating disorders such as binge eating or night eating syndrome. In conclusion, what we have understood that eating behavior is fundamentally biopsychosocial. Hunger and pleasure interact continuously. Emotions strongly influence food choices. Learning and cognition maintain maladaptive eating behavior. Binge eating disorder and night eating syndrome represent distinct but treatable disorders on the same continuum. Early prediction, prevention, and intervention with mind body medicine supports long term health goals. Behind every eating behavior, there is a story waiting to be understood. Thank you.
Thank you, Nikhil sir, to help us understand more about the psychology of eating behaviors. Now we will have a panel discussion. I would request all the speakers of session 1 to come up on stage for our discussion.
So, any questions? We had quite interesting and lot of new findings and new learnings. I think, especially rheumatology and immunology. It was new for me also. Even after working for past 15-20 years, I think I'm hearing this for the first time. But yes, sir, please.
So my question is, when was this PNIE term was coined and who coined it first?
Okay, so I think Padke sir can answer this best.
It actually happened in, you can say, steps. Interestingly, this whole development traces back to 1960s. Scientist called Solomon, who first time uh, demonstrated the association between the mind states and the immunity. So you can say that is the sort of start of that. Of course, several scientists thereafter, they contributed to the development of the whole idea and concept. But as you know that the relationship between psychological states, particularly stress and first hormone cortisol. So Hans Selye was the first person in 1950s. So you can say the association of psychology with endocrine came in the 50s. Then the association between psychological state and immunology was the next one into 60s. But incidentally, in the year India got independent, 1947, there was an association which was demonstrated between, impaired immunity and schizophrenia. So these are the ideas, which sort of isolated group of individuals have perceived in their own right, and thereafter they got consolidated. As you know, primarily because of the development of tools, methodologies. As the more methodologies become available, it became possible, to sort of make these connections and this whole network, and understand this whole biology behind that. But its roots are really very historic in that sense. So it's not some abrupt, sort of development. It's like jigsaw puzzle pieces which people try to add over the years. And now we have a more or less more well-formed, kind of understanding of this whole system. Anyway, the whole understanding is shifting, as you know, in terms of networks. The instead of the just the molecules and the systems, now we are looking in terms of networks, and which has recently got augmented really by the availability of computational power. So as more computation and more AI comes in, perhaps we will be able to correlate these things better. Because as we all know that one of the difficulties in traditional statistics was to actually look at, handling multidimensionality. That was the reason that why many of the experiments in medicine, to my understanding, they're limited to, you can say, a certain set of experimental paradigms, because we did not really have the ability, to look at higher dimensionality. So the idea was to, control the experiment, look at, single variables, etc., etc. Since that now we have the ability, to handle multiple variables together, I am sure. So the whole activity, rather than single factor, it shift to patterns. AI is going to, or it's already giving us this great, tremendous ability, to look at patterns. And I think your daughter
So,
also recently did a network analysis. No, maybe you can
yeah.
tell
So
about that
we
also.
also have a journal called Psychoneuroimmune Endocrinology, which is actually covering lot of basic science articles on the concept. As sir rightly mentioned, there has been no single entity described immediately. It has been stepwise approach. From the endocrine perspective, it has been the HPA axis and the psychology. From the immunological axis, again, it has been immunology with psychology. But to put all the work done globally all together, now we have that journal called as Psychoneuroimmune Endocrinology, which works on this framework of PNI. And this PNI framework has unified all these works together. So this is what has been done. And it is commonly used in neuroscience, not so much in endocrinology. That is why it is new to us as endocrinologists. So I think the applicability is much more to endocrinology and immunology than to neurology.
I have one more question, RK sir. Yeah. So you were when you were presenting, you told one thing. This obesity is because of leptin deficiency. So can we say is it leptin resistance or deficiency or both?
Both.
It is relative
Both.
leptin deficiency, like
So
relative
functional
insulin
deficiency. That is
function. That's it.
all right. Sir.
That is one of the, again in the pattern, it is one of the factors.
Okay.
So the idea is that's what I mean, sir.
Okay.
That in terms of basic science, that the whole idea shifts from a single molecule, a single pathway to actually a whole pattern of disturbance. And as sir rightly said that the more you investigate, it becomes difficult for you to really understand what is upstream and what is downstream. So rather than sort of getting into the typical cause and effect relationship, which was the whole idea in medicine based on the infectious, model, the cause and effect. Now over here we are looking at a whole pattern of disturbance. So what all is disturbed, and that's why now the idea that maybe multiple nodes are disturbed. You can, I mean, there is a leakage in multiple places. You need to fix it in multiple places for the real long-term benefit to happen. So that is the idea. And secondly, she mentioned in her presentation, Professor Norman Sartorius was a very influential person, a former director of World Health Organization. And he was amongst the first ones to point out the deficiency in our medical education that we are increasingly dealing with comorbidity, multimorbidity. Where it's common practice, like she attends my OPD, she knows that any person, any patient who walks into OPD has minimum 4 or 5 diagnoses. I rarely see a person, who comes in actually with a single problem. People have multiple sort of problems. So traditionally, we were not trained for this, to deal with this whole multimorbidity situation. So in clinical terms, we have, instead of a monomorbidity, we have a multimorbidity situation, which we all had to sort of retrain ourselves. It's our effort, to retrain ourselves to sort of into the multimorbidity management. And second part is this, that at the basic science level, it's increasing data availability and the patterns, which should sort of help us, and then define the targets for our intervention. So not just at a molecular level, but even at the systems level also.
There are multiple hormones regulating hunger and
Yes.
satiety.
Yes.
If we have to group them in two groups,
Yes.
three common which
Yes.
regulate hunger and 2-3 hormones which regulate satiety,
Yeah.
what will they be?
Erixogenic and anaerexogenic.
Orexogenic and aroxogenic, two groups that I have mentioned, that set of hormones which promotes hunger and set of hormones which promote satiety. So GLPs, GIPs, they fall under the category of promoting satiety, while ghrelin, it falls under the category of promoting hunger. So insulin is satiety inducer, GIP is satiety, GLP is satiety
So
inducer.
can we simply superficially can we say that except ghrelin, most of the hormones are regulating
Satiety
satiety?
inducing.
Ghrelin is the main.
Actually,
Yes.
cortisol and insulin excess is also hunger inducing. So, insulin works dynamically. If there is insulin
sides.
sensitive, so the best beauty about hormones is that they can work differently at different levels. So, there is dynamicity. So, cortisol excess can make a person eat more, while deficiency can take away hunger. You understand? So basically, the same hormone can work both ways. So I think endocrinology is fascinating because balancing is the key. So you need to have leptin balance, ghrelin balance, GLP balance in the body when you want a normal satiety and hunger. So these hormones are very dynamic. So it's not like A and B are different. It is something which is A plus B also in between, and something behaving like B sometimes, something behaving like A sometimes.
So what you can therefore call as a context dependent actions. And very often many of these relationships, as you know, are U-shaped, which means that the high end is bad, low end is bad. So you are looking actually at some kind of an optimum, optimum range, the U, and the context dependent, depending on the overall. That's why I said that is pattern recognition becomes very important, because once you know that within what pattern is this, particular thing acting. For example, we all are aware, that there is also obesity paradox, that obesity paradoxically is helpful actually, in the outcome of certain disorders. People are also, there are also group of investigators which are investigating that whether it is beneficial to be obese, into certain conditions. So obesity, therefore, as they very nicely said, that is a dysfunctional sort of a adipose tissue which they are looking at, not
was
just
talking
the
about that.
BMI, because under certain circumstances, BMI, excess BMI actually could basically be a benefit.
I think the gist of this session was that we, as doctors treating obesity, need to identify whether the P is the major cause, whether the I is the major cause, whether the N is the major cause. Because suppose inflammation is the major reason for that person's obesity, I may benefit that person better with semaglutide when I know that semaglutide works better for inflammation. But if that patient has psychological issues, it is better I refer to doctor rather than treat with semaglutide alone. So I think acumen development in obesity management will require you to analyze which system is grossly affected in which obese person. So I think you can develop a acumen where the brain is at fault, whether peripheral metabolism, the gut is at fault, whether there is psychology at fault, and then decide what mode of treatment will work the best for you.
For example, if we are to take some common clinical example, there used to be an entity called as a resistant depression. That you give antidepressant to people, they don't get better. Now we know that either it could be, because of the inflammation or because of the insulin resistance. So that is how many patients, shuffle between us because of that reason. They improve actually, So once upon a time, say 20 years ago, which were declared as resistant depression, and you want to try multiple antidepressants, ECTs, all kind of things with these people, they simply improve, once their insulin resistance is helped or once their inflammation goes down. So a lot of resistance cause is also now being understood, that why this particular problem is resistant, why it's not improving.
Yes, sir. One question, sir. Yeah, for binge eating disorder and night eating syndrome, right? So currently, do we have any medicine to treat these conditions, or counseling or behavior, or both needed? What is your comment on that? How do you treat this night eating syndrome?
I think there is one approved medicine, but I am
Which
just
one?
now forgetting the name.
Okay.
I'll may let you know.
Okay,
Uh,
fine.
But most that
It-
also, like ma'am said, you need to have that acumen where that medicine is required or where other mind body interventions are required.
So-
Because how the night eating syndrome is being characterized as, it's morning anorexia, evening hyperphagia, and most of the eating episodes are happening. Maybe there are too much of psychological dominance to maybe a person is self-soothing food, or maybe there are long working hours when a person is getting home tired. Maybe he is trying to find some kind of comfort in those episodes. And when someone is going to bed with this with a full stomach, maybe they are not feel like eating in the mornings, and maybe as the day passes by, their hunger gets stimulated.
So is it imbalance in?
To answer your question, the GLP-1 and the tirzepatide, the dual agonists, are working beneficial for night eating disorders also, because overall there is a improvement in satiety. So they tend to feel less hungry. So it is not a specific for the condition, but overall hunger rates, overall eating rates, overall intervals between two eatings have come down significantly with GLP and the dual analogs. Yes, sir, you please.
Do we have any pathophysiology for that? Which imbalance of which neurotransmitters are responsible leading to this night eating or something like that, binge eating disorder? Particular neurotransmitter is playing important role because of deficiency of one, or excess of something, or imbalance of one or two, leading to this condition.
Hello.
Do we have that?
Most of the times, sir, it is the reward system
Okay.
on which these things work. Because the reward is one very important drive, because human brain needs pleasure. And if anything creates pleasure, the person get addicted to that. So night eating behaviors are typically to generate the pleasant feeling in the brain. So it's the mesolimbic system, the pathway. If it gets activated because of that, dopaminergic pathway, it is a dopamine. So that mainly has, yes.
Dopamine might have some role in this.
What is normal eating behavior? Normal eating behavior or normal circadian rhythm of eating?
Normal circadian rhythm of eating or normal eating behavior. What do you call as normal
Okay, so normal eating behavior is very much individualized because each one has his own rhythm. So there are some people who feel hungry only once a day. Some people who feel hungry every 3 to 4 hours. Some people who feel hungry predominantly at night. Some people feel hungry only in the morning hours. So it is very much derived by many other factors, including how their brain has been wired since childhood. So, a lot of people who have this habit of having breakfast in the school days will continue to have that habit throughout their life. But having said that, there are a lot of people who don't understand hunger. So, they don't know whether I'm hungry. Means it is 8 o'clock in the morning, I don't have hunger pangs, I'm not really hungry, but because everybody is sitting for breakfast, I'm eating. So that is not a circadian rhythm. So ideally what we tell our patients is you need to identify your own circadian rhythm. What are the times when you really feel the hunger pangs and you are supposed to be eating at that time only. That is your time of hunger and that is the time when you should consume maximum amount of food. So it will be very much individualized and that's why Divekar diet will not work for Dikshit diet people and vice versa because everybody has their own time of eating and pattern of eating. So it is very much individualized based on all these systems which madam said. You saw that complex slide, everything decides on how and when you will eat and how much you will eat. So that is what is the pattern that
Because
is.
it is the developmental load that you have seen. If somebody is being trained right from the beginning to eat in a particular way, or somebody is having a system in household that these are the times when one should eat, so it right from the beginning the person lands up in the habit of eating rather than sensing the hunger. So, constitutional load we know, but developmental load also plays a very important role in the eating behavior. So, we have to look for that individuals. Yeah.
Yes, Alka ma'am.
Hi, Dr. Vaishali, Dr. Sanjay Phadke, Nikhil Gupta, Kavita ma'am, and Leena ma'am. Thank you so much. This beautiful discussion, and I heard all the talks from morning. So, one question which sir has asked about what is the treatment for binge eating or night eating or whatever it may be. Cortisol is, we are swimming in cortisol, correct? All of us are swimming in cortisol, yes or no? Leena madam is not. Are we swimming in cortisol, all of us? Are we stressed out for whatever reasons?
Yes.
So one of the things which I have seen in my life is helping my patients is human connection. One of the antidotes to the cortisol is oxytocin. And when we meet people, we get oxytocin from them. Like Madam also said, reward, dopamine, dopaminergic. So people are dopaminergic to us. People bring oxytocin to us. And when we balance out the people in our lives, when we don't have ego in our life, when we reduce our ego in our life, we have better impact on people. And it helps us in eating, sleeping, and everything. So the happiness quotient is very high. So we should depend on people also. Thank you so much.
So rewarding system. Yes, sir, please.
I just wanted to respond. He asked about the normalcy. Like I said, that this now whole understanding in the new adaptive biology about the U-shaped relationship. So there is one more rule. That rule is that the variability is more in normalcy. As abnormalcy happens, there is a constriction, there is a loss of variability. So you will find that when people converge toward diseases, the patterns are more repetitive. In normalcy, the pattern is more variable, whether inter-individual or intra-individual.
We have a lecture on circadian rhythm and food intake tomorrow. Dr. Shreya Sharma from Dehradun will be talking. I think we can take up this question at that moment also.
Hello, ma'am.
Yes, ma'am.
Wonderful sessions, all insights and very beautiful discussion. Thank you to all the speakers for that. I have two questions. So I wanted to know, is the models that you described about eating disorders, are they similar to substance abuse and alcohol addiction? And another question is, so when we said that stress and childhood trauma and all those things are responsible for all this, but some people, in spite of having similar stress, have weight loss or they don't gain weight and some gain weight. So what is the difference in them, and how do then antidepressants, many times we see weight gain as a common adverse effect of antidepressants. So if stress and depression lead to eating and weight gain, how do antidepressants also lead to similar? These are the questions. Thank you.
So your first question, that whether the same biomechanics is active in terms of addictive disorders or substance related disorder addiction. Yes, the answer is yes. So it's the same mechanism that is active there as well. So maybe we are going to talk more about now about eating addiction, food addiction as well.
That is a third rule in adaptive biology. Short-term benefit, long-term problem. Okay, so it always serves a short-term physiological need.
And your second question is about the regulation, that how some people can still regulate because of all the adversities and some people don't. So yes, definitely there is a balance between over regulation and under regulation that might, drive people.
I can add to that was the beginning of positive psychology incidentally. The observation that the same stress, 100 people are exposed, maybe 80 people, 90 people, they experience stress out of it, of that situation. 10% people, they emerge more resilient. And that was the beginning of the so-called positive psychology. That's why I said that is a fourth rule in adaptive biology, that it is highly context dependent. It depends, on the antecedents when you encountered that particular situation. That when the adversity actually becomes an opportunity, and when an adversity really becomes a disease, it is completely decided by the context which is in which you are at that point of time.
And ma'am, your third question about their association with other psychological or psychiatric disorders, I think we are going to have a talk on that.
She wanted an answer on how antidepressants cause obesity.
Yes. Antidepressants cause obesity. See, primarily antidepressants work by enhancing the serotonergic, serotonergic neurotransmission. But that is not the only transmitter, on which it is acting. It is acting on a whole plethora of transmitters, and therefore, basically, the mechanism is bit, you can say, both behavioral and biological. What is the behavioral component actually in the mechanism? So the behavioral component is that when people are relieved from anxiety or depression, particularly those who are anorexic during anxiety and depression. So as per the set point theory, they sort of
खुशी में
spring
भी
back.
खाते और गम में
खुशी
भी
से
खाते
खाते हो. तो इसलिए one is a behavioral route, and second, of course, it's a sort of a biological route which also does this. There is also a third route, which people have more recently discovered, what they call as that the hyperactive children are never obese. What is the reason for that? Why are they not obese? Because they have a lot of fidgeting. So people, once, out of anxiety, if they are fidgety, that whole fidgety, restlessness, agitation, as part of that spectrum becomes less. So there are multiple, you can say, reasons for that.
I have a last question for both our rheumatologists. Now, we have a lot of patients with obesity who come with musculoskeletal pains and edema and a lot of inflammatory symptoms. So, in these patients, do you think that starting them with anti-inflammatory drugs or controlling with GLP-1, what would be the right way to deal? Because most of them have been labeled as fibromyalgias all these years. They've not been labeled as inflammatory pain. So how do you think you should go about with this?
So fibromyalgia is a pain which is there all the time and it doesn't respond to the anti-inflammatory drugs. So definitely NSAIDs are not the solution to fibromyalgia. You can try nocturnal dose of pregabalin or gabapentin. And it's not that the pain is not there. Fibromyalgia pain, people have a low threshold of pain. So there's a lot of, I think, non-pharmacological therapy works better with fibromyalgia. A lot of counseling is required, maybe physiotherapy, etc. Medications, definitely not anti-inflammatory drugs. GLP-1 receptor analogs have not, to my best of my knowledge, studied in fibromyalgia. So I think
and obesity-induced inflammatory pain, not the non-fibromyalgia.
Yeah, but we have to find out why is the pain. Obesity itself causing inflammatory pain. Maybe you try to find out some other cause of inflammation. So you treat the obesity, If the pain goes away, that's fine, but we don't give it just for the pain of obesity-induced inflammation. At least not yet, there are not enough documentation.
So
Hello,
I
ma'am.
think,
I just want to quickly add that GLP-1 agonists are only adjuvants. They cannot replace standard treatment of autoimmune disorders. That's number one. And secondly, just to add, there's so much limited data, as Kavita very rightly said, what's published in New England Medicine. You know, we have something called minimal clinically important difference. Maybe some of you who are conversant with trials and how to read them must have read this minimal clinically important difference. When the trial results are published, they don't tell you whether the outcome has actually exceeded minimal clinically important difference. Now, the trials data so far on GLP-1 agonists in some of the, and very good studies have been published, the pain reduction that is being reported very often is less than minimal clinically important difference on a pain VAS, which should be 1. Now, that means there is a difference. And whenever we are running short of time, I refuse to answer questions actually. So I'm so sorry. I want to put another important point that we all know that we need to differentiate when we look at outcomes, what is clinically significant and what is statistically significant. We all know that, but that we lose track in many of these trials. So with due regards to what's happening on GLP-1 front, we will possibly prospective studies. It's adjuvant. We need to get into outcomes which are more than minimal clinic, and that doesn't happen. As Dr. Phadke said, with new modern technology, so many things are being published. But always ask yourself if in the literature somebody has done work on the outcome which is minimal clinical point of view. You'll be surprised as to how many trials will fall through. That's why steroids are a fascinating drug. It has never fallen through. Whatever outcomes you see good clinical, there are many more times than the clinical. So these are some of the things which I think we must remember. As rheumatologists, we are happy with working with you, and we will always send patients to you.
Thank you so much.
But I would rather wait for the outcome of these drugs, because even the anti-rheumatoid medication that we use, they work on many of these pathways. There's so much redundancy. There's so much of pleiotropic effects. So don't get carried away by, with due respect to you, sir, one transmitter, two transmitters don't mean a damn actually. And एक बात हो आखिर में, patients teach us very often कि मैं ऐसा किया तो अच्छा हो गया. And that beats the hell out of all this what we read.
Yes, last question, please. Yeah.
Yes, ma'am. I have two questions. One is to Dr. Vaishali, ma'am. Yes, this therapy, GLP-1 therapy, it is related to that. So, what is the preferred strategy for maintaining weight loss after discontinuation of GLP-1 drug?
Okay, so I think, yeah, so as I said that the GLP-1 analogs are very useful to work like first aid agents. So suppose you have a patient who has been fighting obesity for years together, is following diet, exercise, and still not being able to control his weight. GLP-1 induction can help that patient achieve a good amount of weight loss within a span of 1 to 2 years. And the literature mentions that with GLP-1 you expect around 20% benefit over 2 years. So this is what we tell our patients. If you ask me what I do, the industry says you should use it lifelong. Literature says you should use it lifelong. I tell my patients we see this, assess this after 2 years. In those 2 years, I expect that you will be habituated to a good diet and exercise routine, and you will be able to follow your routine. And if you are able to sustain that routine after 2 years, we can slowly taper off the GLP-1 and put you on simple drugs like Orlistat or maybe metformin to sustain that achievable weight loss. So this is what I tell my patients as of now, because we don't have long-term data. If the patient can afford and is fine on GLP-1 analog, it is a very safe drug. So there is data of 10 years now with Ozempic. I'm talking about the innovator molecule Ozempic. It has 10 years data and it has no signals which are bad. In fact, there is improvement in survival and overall cardiovascular mortality. That is the data. So if you want to increase your lifespan, it's a good drug. That is what it has been shown. So I think I leave the question to you till the answers are perfect in guidelines. But in practice, at least 2 years is what you should be telling your patients, because you need 6 months at least to up-titrate the medicine. So the tolerance, up-titration, management of the little bit of AEs that occur, all need a 1 to 2 years time to get the appropriate benefit.
Yes, got it, ma'am.
Yeah.
And my second question is to Dr. Kavita, ma'am. As a
Yeah, please.
Yeah, as I'm a patient of her only, so she's my treating doctor for ankylosing spondylitis. I have seen this drug is beneficial in rheumatoid disorders or in what. Uh, so my question is, for ankylosing spondylitis, is there a study or something like that? Ki this drug is
No, I
benefit?
haven't come across a study of GLP-1 receptor analogs and ankylosing spondylitis. So it is not used upfront. As sir said, they are metabolic adjuvants. So whatever studies are there in rheumatic or autoimmune diseases they were used for either obesity or for diabetes. And then they went retrospectively to check one category who received, one who did not receive. And then they found the ones who received had a lot of benefits. Whether the benefit was just because of weight loss, overall, immunomodulation, etc., nobody is very sure yet. But it helps in some category of patients. Ankylosing spondylitis is basically exercise, physiotherapy, lifelong, and you have to treat the inflammation with anti-TNFs or JAK inhibitors, whatever you're taking. And then you wait for the disease to go into remission, and then we can reduce. If the patient is overweight, of a patient of which you are not, so then you can consider, but not for ankylosing spondylitis.
Yes, got it, ma'am.
Yeah.
Thank you.
So thank you all. It was a wonderful panel discussion. And now we move on to the inauguration ceremony. So I hand over to, I think before we start with the inauguration, we have the felicitation, the good duty for felicitation of our speakers.
So yesterday, as you all know, we had a Guru Purnima, and we are really lucky that we have two very senior persons here to bless us, and that's why we thought that let us do this short ceremony of lamp lighting and formal inauguration. So we of course have Chopra sir with us. You just heard him. As you all know, he's one of the senior most and very well respected rheumatologist and a scientist in the domain of rheumatology. So, of course, sir, now it is my pleasure to welcome you, after Vaishali welcomed you in the morning. So, please come, sir. Chopra, sir. The second senior person we have is Professor T.S.S. Rao. Rao, sir, please come so that I can introduce you, sir. So Professor T.S.S. Rao is the president of our National Medical Association, Indian Psychiatric Society. He had a very long association with the JSS Medical University in Mysuru. And he was also the editor of Indian Journal of Psychiatry for a very long time. But the most important thing, as I said, I opened my discussion this morning by saying that obesity used to be an orphan disease. So similarly, there is another speciality or subspecialty which also used to be an orphan called as a sexual medicine. And he is one of the pioneers of sexual medicine in a scientific way in India. He is also very closely associated with the World Psychiatric Association and WHO and the Asian Federation, and he also is the editor of a journal in that domain by Sage Publishers. So Professor T.S.S. Rao and आता Chetan Deshmukh. Yeah, next one is Chetan Deshmukh. Okay, so third one is my pleasure to invite Chetan. Chetan Deshmukh sir, often very low key, is the chair of the Sphere. and he is a very well-known cancer specialist oncologist. He is one of the first ones from Tata Memorial to do his DM and practice oncology. He is also internationally very well renowned because of his participation in clinical trials and academic activities. And so we are really very lucky, that we have people who have been very well known, not just for their medical practice, but in their role as teachers and as in their role of as researchers. Vaishali madam, of course, you all know, and it is her untiring effect, so untiring effort. So as you said that minus her effort, the whole psycho, neuroimmune, endocrine, would have really remained confined actually to the medical journals and medical textbook. So she has very single-mindedly, trying to bring it, the benefits of psychoneuroimmune endocrinology to the patients, So the translation, so she is a great translator. Of course, she has also been active with a lot of international clinical trials, and she is a key opinion leader in her own domain. And we are therefore very happy and lucky. I would also invite Leena Fadke madam, who also is in this elite club. So she recently got a patent for her HR, the autonomic nervous system tele-HRV technology. So she is one of the very few medical persons in India who has got a patent on an engineering technology. Before that, we only knew Valiathan sir. Valiathan sir had the very famous Valiathan sir had a patent on the heart valve which he had developed, and it was also an engineering patent. And Leena joins that elite club, so we are very happy. When we started doing all these things, Vaishali madam thought that it was a good idea, let her send to Harvard to snoop around, as to what they are exactly doing in terms of mind-body medicine. So that is how then she was in Harvard. And we are really very, very lucky that these our seniors as well as these very talented people. So maybe you go ahead, sir, and it's my great pleasure, yeah, to be, yes. Chetan sir, so our Guru Purnima felicitation. Rao sir, आणि Chopra sir.
In this box are made by Dr. Chopra's patients. They are, she is a rheumatoid arthritis patient, and for our function, she has specially designed crochet bouquets, and that is offered for this particular.
Incidentally, we are very happy that Professor T.S.S. Rao was here for the first SYNAPSE conference. So sir, answer. Okay, so Chetan Deshmukh, as the chairperson of the Sphere Trust, Chetan Deshmukh sir.
Yeah. Thank you, Fadke sir. Thank you, the audience, faculty, delegates who've gathered
in a fairly large number. I'm pleasantly surprised to see the hall almost full. Vaishali was having anxious moments in the last few days about how people will receive this meeting, but I must say that your enthusiasm has really give us a lot of strength. I'm a medical oncologist, so some of you may be wondering what exactly I'm doing, but I'm also the president of the parent body SPHERE, which is an acronym for Society for Prevention, Healthcare, Education, and Research. So I'm also the one who's going to sign all the bills for this meeting. And welcome to seventh Synapse meeting. This is the seventh successive year we are doing this meeting. It's a well-planned, very well-designed agenda for the next 4 days. The faculty, Vaishali, all of them have curated the agenda really well. It's an interesting concept, one day of PNIE, and then there will be discussions on that. As a president of SPHERE, it gives me a lot of satisfaction because we are progressing well, not only in stature, but also in the nature of work which you are doing day to day. I remember Vaishali conducting very early days trials on anti-obesity drugs as early as 2007-8. And it has been her idea that we need to integrate the mind aspect of obesity since into the physical, the pharmacological aspects of treatment of obesity. And that idea has been simmering in her brain for a very, very long time. Finally, through SPHERE, we could give her a platform to get this idea to the forefront. And that is how Synapse started. And it's notable that the newer drugs like GLP-1 analogs are also looking at, they focus on the hedonistic part of eating and obesity as well. So that is how they are now looking at the mind aspect of the drug, and it's happening in 2025, 26 when we started in 2007-8. I'm a medical oncologist. I deal with the problems of obesity. It's a major issue in our patients as well. Contrary to popular belief, people actually on cancer treatment tend to gain weight, and after cancer treatment, they tend to get weight even more. So that is actually one of our problems, and already there are papers coming up about GLP-1 analogs preventing reoccurrences of cancer or even primary prevention of cancer. So I hope the pharma industry is listening. Don't be surprised if we start writing these drugs in the near future, or probably in my lifetime, definitely. So our NGO, SPHERE, has started an obesity clinic which deals with the holistic aspects of treatment, and this clinic will help us fulfill our motto of prevention. That was the missing link. We have been doing healthcare activities as a part of our day-to-day work. Our clinical work revolves around healthcare activities. Education, we were imparting education through conferences, through meetings, through health talks, which are again part of our day-to-day activity. Research was happening both for the pharma industry as well as for self-driven research. The missing link was prevention, and I think that missing link will be completed by this clinic. Thank you once again for such an enthusiastic response to all our ventures, not only Synapse, but even previous workshops, meetings, discussions. All have been met with immense success. To me personally, as a president of SPHERE, it's very satisfying. It pushes us to do better and better each year, to do more such activities. Thank you for being here for Synapse, and I hope you all have a wonderful academic feast over the next 4 days. Thank you.
Thank you, Chetan sir. Center for Behavioral Medicine, which is you can say a trust of Niemann's alumni, and its primary focus is actually advancing you can say methodologies, so fundamental research methodologies and technologies is the agenda of this research trust. And it has several collaborations abroad also. So one of the strong collaborations we have is with Germany, and which was launched in 2012, formal association with regards to the autonomic neuroscience of yoga. Autonomic nervous system has a very important role, as you know, and one of the major works of this trust is around developing this whole autonomic neuroscience, and that is from starting from, as I said, developing the equipment to actually developing the methodology, the predictive methodologies, and the use of AI into the predictive methodologies, they have a very famous, Lina and her group have a very famous research about predicting the risk of heart attacks, by simply having the ECG tracings. So CBM is that very recently we have in fact, tried to put all together in the form of this will soon be available. It's a new method of, you can say, a comprehensive health assessment, called as a build on all these modern ideas of adaptive biology, called as a human adaptome. And the model which we have, I think some of us have been repeatedly talking, that on one hand, there is a load, the various, which comes from various factors, and on the other hand, there are protective factors, which work like a net. So it's almost like a net on which you put a load. And you have a possibility to reduce the load, and you also have a possibility to strengthen the net. So something kind of like that. So we also published last year a textbook on clinical trials. Our friend Sarmukadam very well. He's also one of our trustees. So Sarmukadam wrote a full-length textbook on clinical trials, recognizing that there is a dearth of clinical trial textbooks in India. We don't really have people, those who are interested to do good quality clinical trials. This textbook is available. There is other one, so we are into this sort of publishing. So this much is about the sphere and the Center for Behavioral Medicine. Our partnership has been ongoing, and one of the mantra which Norman Sartorius gave us in 2019, that build the social capital. It's very important to advance the science, so you must have friends around you who are interested in this agenda and to sort of take it forward in a systematic way. NIMANS has also been a very important partner in this. My friend and colleague, Professor Shivram, he will arrive here shortly. You will also have his lecture. So over the period of time, I think the credit also goes to Vaishali Deshmukh to build this great network in India. A lot of people from multiple institutions are sort of connected within the basic science as well as clinic science space of it. Having said that, my pleasure that Professor Rao, just for a few hours, he traveled to Pune. So whole night yesterday he spent in travel from Mysore to Pune, and tonight he goes to Jaipur. But he agreed to give us this, flying visit and to give his blessings. We thought it was very important, because he was personally here for the first SYNAPSE conference in 2020. And that's why it's very necessary, since he is now the president of Indian Psychiatric Society. So his blessings become more important to us. So Professor Rao, sir.
Good morning, all. Personally, I'm really grateful to Dr. Vaishali Madam, Dr. Padke, Leena, and all the people who are associated with it. Leena and Padke had come to Mandya, my house. And after seeing Padke, she says, "You've become one like Padke." This is the problem I have at home. So he's a man who solves the problem and creates the problems too. Coming to Indian Psychiatric Society, Indian Psychiatric Society is extremely happy to be associated with this, and Dr. Padke, Dr. Marwale, and others. In fact, there are two special sections in Indian Psychiatric Society dealing with a lot of issues. And one important emphasis what they have brought into the Indian Psychiatric Society is psychosomatic medicine is one of the extremely important area, and that need to be attended. We also got some extent inspired by this particular family, wherein the engineering and lot many others these things. And when we look at our sexual medicine area, there are hardly any worthwhile instruments available, though we have 1.4 billion population with any number of people who are actually having sexual problems. So we are developing something called as erectometer, one of the scale-based one, and other one is the Regiscan. In fact, we had brought it from America for about 12 lakhs, but it worked for only about 2 months or so, then beyond which we are not able to use it properly. And a simple device which anybody in any clinic, even as an inpatient or outpatient, one can use it. This is a small idea what I just wanted to convey the message. the emphasis being given to sexual medicine, I'm extremely happy because this is one of the area we are working on. And as co-chairperson of World Psychiatric Association Sexuality Section and other major associations which are concerned with South Asian Society for Sexual Medicine, we are trying to emphasize. See, in our JSS, our sexual medicine clinic is next to diabetes clinic. The diabetologist was telling Rao, they don't listen to me, this, that, and all like earlier. But now he says, Rao, since you have come as a neighbor, my practice has improved very significantly. I was asking what is the reason. See, now I tell them that if you don't follow diet, don't take medicines properly, don't do exercise, you will end up in the next department. Now he says everybody is so serious about diet control and taking medicines and what we basically call all that what he was trying to put effort in. This one word, sex, brings about a lot of changes. I am extremely happy the inaugural function was everybody standing. That is our sexual medicine motto. But all said and done, we sexologists like something called foreplay. Maybe we made us to say it and talk something, this and all like that is what you call as foreplay. And maybe this is the first time I'm purely focusing on obesity later. And when I started reading, see, very commonly we used to talk about metabolic syndromes in general, but never obesity as a particular focus area we used to look into. I really don't know, but I'm 73 years, no diabetes, very mild hypertension, no prostate problem. And my wife says, your abdomen is coming forward and another few extra millimeters, I will leave you and go. You got the point. I really don't know whether to bring extra fat into the abdomen or reduce it. You got the point?
No telling lies over here. Your wife will never say that to you.
But all said and done, something happens. See, for example, if I eat 50 gram, I add 500 gram weight. I really don't know. That means there is something really happening there. And one important point, there are multifactorial way we have to look into. Somebody was asking, why with antidepressant people put on weight? One of the most common, say for example, you remember yourself when you quarreled with your husband, you eat or you don't eat? You don't eat.
Eat a lot.
Once he leaves the house, you eat, almost you empty the fridge. No, you got the point? Hunger, more particularly women, use it as one of the methods to overcome stress. They are not healthy methods, but this is actually very well documented. This thing. Not only this, there are multiple other behavior issues are there. That means what I am trying to convey the message is, there is a whole range of scope for combining psychological, social, biological aspects and understand. I am extremely happy, very focused to work on obesity is happening because as I can make out, all the time we used to talk about one word which is extremely commonly spoken is actually sex. After coffee, this may be the second most common word. But now since some of these drugs have come, everybody is talking about obesity. No, you got the point? They ask us, they inquire, they read, and in fact, Google University, in fact, so much of things are happening. So a significant focused work is something extraordinary. And I congratulate the people who are organizing and for all the effort what you have put up. In fact, with such love and affection, you people were there behind me to come over here. I am extremely happy about it. Thank you very much and all the best.